there's different various factors that are driving this. But it's not for lack of appreciation of why robotics has benefit to our patients. And you'll hear from some of our patients later today. I think surgeons and physicians understand that there are benefits to robotic surgery, not just to the patients, but to the surgeon as well. As you can see, the robotic surgeon console in the corner there, we can operate while we're sitting down, as opposed to having to stand for 6-8 hours. We can sit down theoretically with our coffee just next to us there. So it's a benefit to surgeons as well. One of the biggest limitations or impediments to really wide adoption here in Canada has been cost. Like with any new innovative technology, it's usually the newest, best thing is not cheaper than what we had before. You will hear a lot of discussion later on this afternoon about cost, and I have my own take on it. I won't talk about that. I only have 20 minutes here. One thing I will say, and Intuitive may not like this, but we do have a bunch of competitors really starting to push the market now. We have a variety of robotic surgery platforms that are about to make a big splash or have made a splash within the last 12 months or so. I think the technology is still not quite where Intuitive is, but it's exciting. And I think ultimately, I don't think anyone can argue that competition is good for the consumer, driving prices down, but it's also good to sort of really push innovation. I think that's what we need moving forward. Until that time, Da Vinci is still the king here. The other thing that has been really a bit of an issue, particularly in the US, was safety. Some of you may have heard about all these class action lawsuits in the US about robots causing all kinds of harm in the patients. The reality is robotic surgery is not yet, anyway, artificial intelligence. It's still remote control surgery. Not to throw any of my colleagues, surgeons, under the bus, but for the most part, it wasn't the robot causing harm. It was surgeons who were not probably adequately trained. Market forces were pushing things in the US. So it's not the robot that put a hole in the vein by itself. It was probably a surgeon or the surgical team that ran into some trouble. So despite what these patients and their lawyers would suggest, it wasn't Skynet, Terminator going crazy inside the patient. It's still just remote control surgery. I think one thing that partly driven by finances, what we've done well in Canada is we've really judiciously adopted robotics. And I think unlike putting up a robot in every single hospital across the country, we've done this in a very measured manner. And I think that's good. I think surgeons here in Canada have really, partly because we're not, driven by the same financial motivations as perhaps in the US, but we've really been slow to adopt these technologies. Some people think that as a negative, but I think that's a positive. We really have trained our surgeons well and ensured that they sort of met some sort of safety criteria before allowing them to operate in the patient care realm. Here at University of Toronto, for the last few years, in collaboration with several other divisions, every summer when we have an on-ramping of new fellows and residents, we've run this comprehensive surgical or robotic surgery training program. It's mainly for basic skills. The residents and fellows and any interested faculty members have had a chance to really have didactic lectures, hands-on training in the OR and with simulation. So it's really sort of decreased that learning curve with robotics. Robotics has been revolutionary over the last decade, but now as we're seeing other technologies really integrate into the robotics platform, I think it's really just an evolution of surgery. And I think we need to continue to adopt and foster robotic surgery. I know there's cost issues that we'll talk about later this afternoon, but we really need to do this, especially in Canada. We don't want to be left behind. One thing that we're really understanding is the importance of training, as I've mentioned. Intuitive Surgical and other innovative surgical technology companies have really focused on the training aspect of it. We are now providing, the surgeons of tomorrow, a whole host of resources, online and otherwise, to really improve their skills. I think the day of learning how to operate for the first time on a patient are gone. Like, we shouldn't be doing that. We should be doing that in the simulation center. As mentioned before, we're working on developing an amazing simulation center here just behind us at the Michener Institute. Companies like Intuitive are providing all kinds of resources for surgeons to really get over that safety learning curve, such that when they're in the OR for the first time, they really can focus on outcomes and not where the heck is my left arm, I can't see it, I don't know how to move it. I mean, that's how things started in the US, I think, several years ago, and why we got into trouble. Some of the very exciting things that are coming down, as people much smarter than I am are working in technology labs to really integrate things like augmented reality, artificial intelligence, machine learning. We can now actually integrate real patient data. So upload the patient's CT scan into the simulated environment, and soon enough we'll be able to practice the night before the exact surgery we're going to do the next day, and encounter any complications that we may run into in a simulated scenario, so that there'll be no sort of surprises. Now listen, you know, there's the old adage that if you never have complications, it's because you haven't operated enough. Listen, it's not going to be perfect, but I think the day where we run into surprises in the OR are gone. I think we can really harness this kind of technology in the training setting and sort of minimize the footprint of surgical education. I think not too far in the distant future, we'll get to the point where these surgical platforms, with machine learning, uploading of all the data that can come from these surgical platforms, really help us operate. I think the robot itself doesn't make a bad surgeon good right now, but in the future, I can totally see where this technology will tell us, hey, watch out for the renal vein. It's just behind that little pad of fat. We can upload their patient anatomy right into the operative field that we're looking at, and so that the robotic platform will tell us, hey, you will have better outcomes if you take this plane as opposed to that plane. And all of this kind of training and improved performance is something that is within our grasp now with improved technology. So listen, at the end of the day, as a surgical educator, my job is to make sure that the future robotic surgeons are better than I am, which is not saying too much. It's a low bar, but we want them to be able to harness and push innovation and become better surgeons than what we have now. And ultimately, we're here to improve the outcomes for our patients. But if nothing else, I think we should continue to push robotics, partly because as a surgeon, it's much easier to operate on the robot. We know that surgeons have a lot of orthopedic injuries, and it's much easier for me to sit at the console and operate all day than have to stand and operate. And you know, people have said that necessity is the mother of invention. I would say laziness is the father. And so we need to continue to move this kind of innovation forward. So thanks very much.
The robot more, you wouldn't have the voice problem. It's a known thing, being on the robot can save your voice as well, so we're pushing that. I think our next speaker I know very, very well. I've worked with her for many years and was a mentor of mine getting into the field. I feel we actually have a connection before I introduce her, because he is here today as one woman among 6 men. Every day I am one man among 7 women, which are my partners in crime at the University Health Network. So I can also say that she is one woman equal to 6 men, so I know her very well. Dr. Murphy is the program chief and medical director at the Women's and Children's Program at the Trillium Health Partners, and she's a full professor at the University of Toronto. She has practiced robotic surgery from the advent at UHN and has been instrumental in introducing the robotic surgery platform at Trillium Partners, and she's going to talk to us a little bit about the implementation of that type of program. Joan.
Thank you very much, Marcus. This wouldn't be the first time I was the only woman on the podium, token or otherwise, but to be frank, when this brouhaha erupted, my interest was equally in having someone from other than a non-academic health science center at the podium as part of this meeting. People like places like Trillium are here. We're here to stay, I hope, and we have a great deal to offer. So I look forward to all sorts of ongoing, I was going to say collusion, I guess I mean collaboration with our academic health science partners. I'd also like to recognize that several other of my colleagues from Trillium Health Partners are in the room today, and this work is much more to their credit than to mine. However, I'm delighted to be here for whatever reason. I just figured out I ticked another box too. I ticked the first two, the female and the community hospital, but I'm probably the most senior person on the podium, so this is diversity in action, I guess. I'm still standing though. So who is Trillium Health Partners? What are we? Well, we often struggle with that ourselves, but we are basically the amalgamation of three different health centers, the Mississauga and Queensway Health Center and Credit Valley Hospital. This took place in 2012. We're about 1,250 beds, and that's not counting our surge beds, and that's not counting some of our hallway beds, et cetera. So we're a big place. We serve about 1.2 million people in the LHIN, if LHINs matter anymore, but certainly in our region. We serve a great, humongous population, rapidly growing. We have a high level of diversity. So it's a really complex organization. The two community hospitals amalgamated. We also instituted the Mississauga Academy of Medicine at about the same time. We instituted the Institute for Better Health, which is our research arm, and we're fully, whatever that means, affiliated with U of T. So we have gone from a community hospital to the next level, whatever that is. Having said that, we are not an academic health science center. We have many regional programs active at Trillium Health Partners, one of which is the Cancer Center, and that is a large part of what we do in our robotics program. So I think many of us have forgotten that there was a report, a technology report, before the HQO report came out. But this was done in 2011 at a federal level and by CADITH. And in fact, this was an HTA that was meant to assess clinical effectiveness and cost effectiveness of robotic surgery. And it was actually very interesting and quite exciting. They found that there was a statistically significant improvement in length of stay, in blood loss and blood transfusion, in post-op complications, and also a decrease in positive margins for radical prostatectomies. It was found that there was an increase in operating time, but that was expected. So that was then. And then came the 2017 robotic report from HQO. This was an Ontario-based report, but it actually recommended that we not invest public funds in robotic surgery because it does not provide good value for money. So where did that leave us? Well, at Trillium Health Partners, this is where it all started. This was in 2012. These are our three of our urologists, and probably more importantly, Hurricane Hazel McCallion. And I've discovered since in the 4 years since I've been in Mississauga that once you get Hazel behind your cause, you're golden. So I think success would have been predictable just by knowing that Hazel was behind it all. But two of our urologists, the head of our urology division, and our chief of surgery, who is also a urologist, did the heavy lifting on this project. Gynonc was involved, but we were a very small and somewhat, shall we say, nascent program at the time. So the urologists, I have to say, did a lot of heavy lifting, working with our senior executive, working with our foundation, and raising money and building a plan. And that's really a large part what I want to say is that we built a plan. It was a comprehensive plan, and it was a long-range plan. However, when it was well underway, when this 2017 report came out, and as I've said, it really showed that robotically performed surgery is expensive compared with any other, and this panel was unable to identify reasons that investment would pay off in robotic surgery. So at that point, we were pretty close. We've been working with Minogue, we've been working with many others, and when that hit the press, there we were hanging from the cliff, not knowing the check hadn't been signed, the final decision had not been made. However, at that point, our CEO, who had been converted to the cause some time ago, rolled up her sleeves and did some very novel and innovative work, working with other CEOs, working with Cancer Care Ontario. And I think, Danny, do you still have the bruises from that interaction? I think you probably, yeah. But she understood our vision, she accepted our vision, and she bought in. And so at that point, having worked already 4 years with our board and et cetera, all these other partners, our CEO and our senior leadership reaffirmed and recommended to the board that we stick with the plan, that we stay the course. We had worked out, and I say the royal we, as I say, I'm relatively new to the process, but certainly became involved once I went to Trillium in 2015. We had been planning a 5 to 6 year horizon with our funding, with our planning, et cetera. In fact, we were pushed to say, no, you have to make this a 10-year horizon. 6 years, 5 years is not going to be enough. You're not going to build it well enough, and we don't know, we're not confident we will have stable funding at that point. So we managed to do that by all sorts of different machinations, which unfortunately did not include the foundation going back to the well with our donors for a variety of reasons, but we've managed to do that. The board and our CEO were also very, very clear. We're going to move forward with this, but it must include continuous monitoring, continuous evaluation of our progress, and continuous refreshing of our vision, as well as a significant research component. One way that these people were invested, our administration, our board, our community, was that we focused on, we anchored on the values of our organization, which are quality, access, and sustainability. And so we were able to convince our leadership, who were spending the money, that we were going to offer high quality care, first of all, with our radical Ps, that we could offer MIS treatment, which wasn't available to our community up until then, and with significant proportion of people needing radical prostatectomy in our community were going elsewhere. We also knew that we could do better care, we could provide better care for especially for the morbidly obese in gynecologic oncology. Up until then, we could only provide laparoscopy, and as we had learned at UHN in our implementation, there was a significant gap. Those women were at higher risk of being unsuccessful in having laparoscopic surgery, and they were at highest risk for having laparotomies as well. The access issue was very important, and that's maybe a little bit different than academic health science centers. The academic health science community is the knowledge community and is a tertiary and quaternary referral base. Our first responsibility is to our geographic community, and I think that was bought into very heavily by our leadership, that it was our responsibility to make a full course, a full suite of services available to our community. The other issue was sustainability. And we did anchor quite a bit on reputation, and to Jason's point also on teaching. We knew that we weren't going to be able to attract high quality surgeons and retain them, nor were we going to be able to go toe to toe with the other members, or the other hospitals involved with residency and fellowship training if we couldn't offer some ability to do robotic surgery. And so all of that was accepted, and we were to push forward. I put this up just as an example of our governance structure once we got our implementation plan underway. Many of the names have changed, except maybe Munir's and mine, so please don't pay attention to the names. But what I wanted to point out to you is that there was very careful planning. We pitched a very wide tent. We included people from administration, from nursing, from anesthesia, from all of the different players that were going to play a role in making this a successful implementation. We met monthly for what seemed like a very long time before we were ready to go live. We happened to have a construction, a redevelopment project going on, so that really anchored us to dates in some ways. We didn't want to implement before our new space was available for a number of reasons. But ultimately we were able to go ahead. Prior to go live, of course, the training and learning curve was really important. So we assembled our full team. We worked very closely with Minogue. And I meant to mention in this governance structure, we also embedded, first of all, anesthesia, who you don't find on this map, but anesthesia, as you all know, is critical to success in robotics. And we also worked very closely with Minogue, and they sat with us at our governance table with many, if not all, of our meetings. And so that was critical, because training and learning they were instrumental in all of those systems. Our nursing team did all sorts of due diligence, made visits, had teleconferences with robotic centers that were up and running. We identified who in our nursing team, and our coordinator is in the room today. And Joanne, thank you very much for all of your efforts. We identified the nurses who would be on the team. We actually have an RN First Assist who actually is dedicated to the robotics program, and that's been very helpful. That is meant to say anesthesiologists. I'm not sure what happened to it. Urologists, I'm sorry, anesthetists and gyne-oncologists. Again, this is preaching to the choir in many situations for many of you, but for some of you who may be earlier in your journey, you know, having been a robotic surgeon, I was hell-bent to get on the console. But it became very obvious that the investment should be in the younger people who had a longer pathway, and so I'm actually not on the console, much to my chagrin, but the investment in our young people is very much worth it. We trained through Minogue and the Da Vinci Lab in the States, and we set up a protocol of 2 cases per week per surgeon, which was not the pathway we had intended, but we were convinced by other people who've done this before us and by others, by Minogue and others, that was the way to go. We had the technology support, and then we of course had preceptorships. We have also, this is just to show you that, again, our startup pathway was very carefully mapped out. You can tell, I'm sure, by the colors and the shapes and the Gantt charts that we actually had certified project managers on this who confused us almost every meeting with moving the boxes around. But just again, up to our install day, we had many, many pages of charts and deliverables. And then finally, we took delivery of our robot. And again, this is one of our robotic surgeons, one of our OR staff, and Dr. Short, our chief of surgery, that was a very happy day for all of us. That was not go live date. I don't know who made the decision to do the first case on my birthday, but it was a really nice present. So thanks very much for that. And this, again, is just an example to show you, again, we now meet bi-monthly, but we were meeting monthly. And this is the kind of infographic that we came up with that we go over every time. How many cases have we done? Who's doing their cases, the cases? What have we done their surgical safety checklist? How many visits to the ER from a robotic surgery patient? Are we on track? And what we go through costing, and we go through supplies, and do we have our just-in-time disposables, et cetera, et cetera. We also go through our data. Are we capturing all our data correctly? And we update that with every visit, with every meeting that we have. We have a tremendous analytics group who help us with our data sharing. So this dashboard is completed, as I say, every month. So I think I'm going to conclude there. I think the point is a lot of planning, a lot of effort, some of which seems a little bit daunting as you go through it. Getting buy-in, establishing a vision of what you're trying to do. It's not just doing surgery a different way. It's providing this whole program to our organization and to our community. And getting the buy-in of senior leadership is absolutely critical. We thought aligning our vision with our corporate strategy and values, which is quality, access, and sustainability, was the only way to go through this, to make it understandable to our leadership and to our board. We believe that we're offering clinical excellence, operational excellence, and executive leadership, that by doing so, we will have a sustainable and safe program. We're working very hard to maintain our long-term vision. Funding has been mentioned a couple of times this afternoon already, and certainly funding is probably the unknown, the bugaboo that's very hardest to work with because it's unstable at the moment. Communicating with all of our partners throughout the hospital and throughout the program is really important, and we have a few here of our nursing staff. And I would like to just say a little bit more about our research partnership with the Institute for Better Health. We are, as I say, not an academic health science center. We do have a research institute. We are focusing, we're probably not going to solve the cost effectiveness issue. It's much larger and more robust academic programs have failed to do so. We will, however, focus on the patient experience and patient-reported outcomes, which is very important. Having been in this game now for over 10 years, I strongly believe that it's the patient experience that is better. We as surgeons know when we can do a better job for patients. It's very hard to quantify that on a spreadsheet. And so we're hoping that the patient experience data will be helpful in making our arguments be more resonant, if you will, with funders, et cetera. So where are we going next? Well, we have made it very clear to our leadership that we believe that diversifying the platform, probably getting into, we're doing only radical prostatectomies at the moment. We hope to get into other urologic procedures. In gynecologic oncology, we're doing some ovarian cancer debulking, both primary and interval, and we're trying to find the sweet spot. When does it make it better for patients for us to do that? We'd very much like to get into thoracic robotic surgery. We have a coterie of very enthused thoracic surgeons, and we think we can do better things for patients in that area as well. We just need to solve the funding gap because thought Kevin was going to give us a lot of money, but I guess not, eh? No? Okay. Anyway, thank you very much for listening. I hope it's been useful to some of you in your process.
Thank you very much, Joan. I think you make an excellent point. Obviously, this is all about the patient. I mean, I think we do our best as clinicians to try to provide that. We have the opportunity to hear, in fact, from two patients. I'd like to bring up Nick Cantus, if Nick can come up. And then also we have Dr. Gwendolyn Jantz. I don't know if maybe if you want to just we'll do one at a from both sides. So why don't you come here, Nick, and then.
So my name is Nick Cantus. I was a patient, well, long story short, August 29th, a day before my 47th birthday. I got a call to come to the doctor. And anyway, sorry. And to tell me about something they had found. And so I went, and at the time I was going through some back problems and all that, so I was really, I thought that it had something to do with my back. So they called me in, and I was going through some testing, some CAT scans and all that, MRIs, and they called me in and they said, hey, we found that you had a slip disc and all that sort of stuff. But we also found something that you might not be aware of, and that was we found something in your kidney. At that point, I was very healthy. I had no symptoms. So they basically told me it was renal cell carcinoma. At that point, I didn't even know what that word was, or those three words. Hadn't heard about it. Again, the next day I was turning 47. I'm married. I had a 9-year-old daughter. And anyway, so I was really confused, and I didn't get it. And the doctor sat me down and said, look, I'm sorry, but this is it. And you kind of, everything kind of stops there for you. I remember her hand movements. I remember everything. Moving forward, she said, we're going to get some appointments set up for you and all that sort of stuff. I remember the first place I was told to go was to, they set up an appointment, was to Sunnybrook. And I met with a doctor there, very, very nice guy, Dr. Nam. He sat down with me, and he put me at ease, and he said, hey, listen, it's a very small tumor. It's something that we can manage. It's something that, has a really good prognosis. And, your anxiety levels don't need to be that high. I understand. I completely get where you're at. But, you just got to, tone it down a bit, and I think we're going to be okay. And that took about 3 weeks to get there and all that. In the meantime, you go through this phase of why me, what's going on, what did I do? Is it the job I'm in? Whatever. I apologize. I didn't think I'd be so emotional about this. I'm not an emotional guy, because that's my wife. Anyway, long story short, I'm sorry to say that, but anyway, I started doing my own research. And as I was doing my research, I came across a video, and there was a surgeon doing a conference like this. His name was Dr. Finelli. And I had no clue about medicine. I didn't understand any of this, none of the terminologies. But once you're in the game and you're fighting, you take a little bit more of an interest in things. And I started, watching this video on YouTube. And he was talking about robotic surgery. And I remember I was down in the basement and I ran up to my wife and I said to her, I got to see this guy. And she's like, what? And I even said, even my brother-in-law is here today, and I sent him a video. I sent everybody this video. And it just gave me this hope that, you know, there was more than just one option. So I went back to my doctor and I said, hey, you know, I saw Dr. Nam and I went to Sunnybrook and they're offering me an open surgery, but I saw that there's these other options and robotic was one of them. And they said to me that, well, you know, that there's a list on that and we don't know. And I said, can you please put in the referral? And they said to me, we'll try. I said, okay. You have to understand when they say that to you, you have this thing growing inside you and you don't know, you know, what that means until you know, they tell you, well, you know, it's here or here, what kind of grade it is and all that sort of stuff. I finally got to see Dr. Finelli, I believe it was November, about a year ago. I sat down with him and he says to me, hey, you know, this is manageable, but I got the right guy for you. And his name is Dr. Jason Lee. And the problem with my tumor was, it wasn't that it was in a weird spot, but it was because on the back of the kidney. And there's a terminology, Dr. Bernini, what it's a retro, yeah, one of those big words that you guys all use. And anyway, he said to me, this is your guy. You got to see him. I'm going to put the referral in, and you're going to be in good hands. Let me just first say I want to thank all of you for being here and giving me this platform to tell my story, because it's very important. Because there's going to be another Nick Cantus who will go through this. I didn't think it was going to happen to me, just like all the patients that you come across don't think it's going to happen to them. And when you have a young family, or you know, it doesn't matter. But the bottom line is, it's not really about you, it's about the people around you and how that affects them. I didn't want to tell anybody. I kept it to myself for a while because I didn't believe it. I asked, do I have cancer? And they say, oh yeah, you have cancer. So I believe I had the best care team in place. And why do I bring this up is because when they first told me, I was like a chicken without a head running around. I got to see this guy. I was going to go to the US. I was going to do this. And I started doing my research, and I found out like we have one of the best healthcare systems. You know what? I did not have to think about where or who I had to see. I didn't have to worry about money. So when people say that, you know, our healthcare system sucks, no. Look at me. I didn't have to think about that. I had to think about getting better for my family. I sat down with Dr. Jason Lee. He said, listen, we're going to do this, this, and that. I said, okay. I felt 100% confident in his recommendations. I had to sign the paper. I did that. And then between, I believe, November, December, when I did that, till February 13th, I just kind of, you know, I laid low. I wasn't working. I work for Air Canada. I'm a flight attendant. I didn't want to be stuck on the other side of the world. If something went wrong, my company understood. I went to the surgery. I felt okay after I got out of it. I think the next day I was sent home. I felt a little bit bloated. But for the most part, pain was not an issue. I don't even think I took pain medication when I went home. The one thing that sticks out to me is I had a 9-year-old daughter, or 10-year-old daughter, now she's 11. Within 2 weeks, 2.5 weeks, we were wrestling. She's pretty feisty. And, you know, I had this, you know, I just went through this major. But the fact of the matter is I was able to do things that I don't know if I was cut open, if that would be possible, or whatever the case may be. I can't give you a perspective on what an open surgery or other procedure would be, but what I can tell you is I feel in the bottom of my heart that this was a procedure that really benefited me and was the best solution for me to get back to where I needed to be. I just had my 6-month, I believe, ultrasound September. It came back negative, and so I'm happy about that. I know it's, you know, every year it's going to be one of those, because, you know, the anxiety levels go up. But if I have anything to add to this and put some meat on the bone, as far as a perspective from the surface as a patient, what did I find the most challenging was, I didn't know about this. So awareness, I didn't feel that my initial point of contact, my care, as far as my doctor telling me they didn't give me this option. So if there could be some more education on stuff like this, more awareness, and then access. I believe if I had the opportunity to be treated like this, I hope one day someone who's in my situation will get that same opportunity. You can't look at this as, you know, as that saying is, where it's, you know, everybody looks at the cost of everything and the value of nothing. I believe this adds a lot of value, and it's just not based on numbers. I'm not a number, and because of this, I think I'm going to be okay. Thank you.
Some very powerful words, Nick, and thank you for sharing your story. That's never easy. We tried to get someone a bit more emotional up here, but you know, I think we heard a lot of what you said, Nick, but I'll tell you that there's a lot of people in the room that what's sort of cycling in their head is, sorry, he had his kidney out and was home the next day, didn't take painkillers, and was wrestling with his daughter a couple weeks later. And that's probably a pretty impressive element to your story. Gwendolyn, would you like to say a few words? We'll hear from Gwendolyn, and then we'll take a short break.
Okay, so my name's Gwen Jantz, and I've been a practicing family physician here in Toronto since 1992. And almost all of my interactions prior to this year with the healthcare system was as a provider. But I'm going to tell you about my experiences as a patient receiving care in the form of robotic surgery. After I had a significant shift in the pattern of perimenopausal bleeding over the last year, led to an endometrial biopsy, and I was diagnosed with endometrial cancer in May of this year. The first thing I did was had a quasi-panic attack, but the first thing I did after that was to read the NCI database on endometrial cancer. The takeaway message that I gleaned from the summary and studies that I read was that a total hysterectomy in the earliest stages could have the best outcomes with essentially surgical cure. Okay? And this is what I wanted, surgical cure. So I knew surgery was in my future, so my next internet stop was the American College of Surgeons surgical risk calculation, of course. So late at night, I'm plugging my health and risk factors into the calculator, and I had appreciable surgical risk, okay? Less risk for closed laparoscopic surgery than for open laparotomy. So the first thing I thought about was, could I lower my surgical risk if I had a substantial weight loss? But the only treatment that I could think of that would give me that rapid weight loss would be bariatric surgery. And if I was going to accept a surgical risk, I would rather deal with the cancer first. Okay? I did speak with an endocrinologist, and I started a very low-carb, low-calorie diet, similar to the prep for patients who would be undergoing bariatric surgery. But I was very conscious of the amount of time any bariatric intervention would take to yield the large weight loss needed to significantly lower my surgical risk. If the cancer had spread to the myometrium only, I'd be looking at radiation as well. Further spread would require chemotherapy. Although intellectually I know that endometrial cancer is often indolent in the early stages, one of my very good friends had died earlier this year of uterine cancer that was metastasized before diagnosis. I have 2 young daughters, just in undergrad, and my husband was diagnosed with metastatic prostate cancer 2 years ago. Even a 6-month delay for surgery with no guarantee of substantive decrease in surgical risk and no guarantee of no spread was untenable for me and for my family. It had been suggested that I have robotically assisted laparoscopic surgery for the total hysterectomy, a way for the surgery itself to address some of my surgical risk. I had actually read a paper by Dr. Bernardini and his colleagues comparing complications of robotic surgery with laparoscopic surgery in women with high BMI having total hysterectomies for endometrial cancer. It was very nice of you to do that study for me. I appreciated it. And there was a lower rate of complications with the robotic surgery, with included converting to open laparotomy, which was one of my greatest fears. With the usual laparoscopic hysterectomy, the incisions for the instrument placement is in the umbilicus in the lower abdomen, which would be certainly a problem given my body habitus. With the robotic surgery, the incisions for the instrument placement are higher in the abdomen, where the pannus would be less of a problem. And as I understand it, the platform for the robotic surgery itself would take some of the weight of the obese abdomen, especially during surgery when in Trendelenburg my head's down. And that decreased my risk for airway compromise, allowing the anesthesiologist to better ventilate an obese patient. I had the robotic surgery in August, and the pathology showed the cancer was restricted to the endometrium, so no radiation and chemo for me. I'd had previous abdominal and pelvic surgery. I actually had a diagnostic laparoscopy for pelvic pain about 38 years ago, followed by a laparotomy for surgical treatment of endometriosis a couple of years later when medical treatment failed. And I had a lap chole about 22 years ago. Despite being much, much younger at those times and not being obese at those times, my recovery post-op was actually best for the robotic surgery. I had about a 1 to 2 day stay for the lap chole. Now, it was done acutely, which might have cured, why I had the stay. But with the laparotomy, I was in hospital for about 4 to 5 days, partially for management of blood loss, but partially for pain management. In fact, I recall I used narcotics for probably about 2 weeks at the time of the laparotomy. And it was a good 6+ weeks before I was back to my usual activities of daily living. With the surgery in August, I actually walked out of the hospital about 12 hours after the surgery started. I was using my walker, but that's more for my arthritis than any limitations post-op. And I was able to walk upstairs to my bedroom once I got home. I only required Tylenol extra strength for pain post-op, and I was back teaching my med residents and students in about 3 weeks, and back to clinic full-time in 5. Probably could have gone back earlier, but I already had a locum, so hey, I took the time off. Okay? I'm not saying that robotic surgery is medically necessary for everyone, okay? But for me, with my health limitations and the higher surgical risk, it allowed me to have the surgery I required safely in a timely manner, and it allowed for the best outcome for me and my family. And I'm very, very grateful to be able to have had this surgery here at UHN. Thanks.
Thank you, Gwendolyn. We are running a little behind, although we did start a little late. So what we've just maybe asking that we take only a 10-minute break or maybe a 7-minute break and try to resume around 3:30 if that's possible. Just stretch your legs and we'll get started again. Okay, if we can get everyone to take a seat. It's good that there's a lot of discussion, and I'm sure we can continue it after the. So as we continue with the session, you're going to hear from three speakers, myself being one of them, and then there'll be a panel that'll be led by Dr. Tony Finelli, who I will introduce a little bit later. So you heard a little bit in the talk this morning. I think we've had some evidence of the benefit of robotics, not just in terms of some of the outcomes of the data that's been presented, but also you've heard from patients. What nobody wants to talk about is the topic that I was given, which is basically the total cost of care. And it is an important part of the discussion. So just in terms of conflict of interest with every presentation, I have acted as a proctor for Minogue Medical, helping some new centers in terms of get their robotics program off the ground, and I have participated in advisory boards for AstraZeneca, but none of that I think will impact this presentation for today. What I'm just going to go over is just in terms of some elements in terms of the cost of new healthcare, cost of robotics, and the cost in terms of different healthcare systems and how that difference may play out. Some data from US and Canadian. I'll really focus on gynecologic oncology, which is my area of expertise. Some costing data that's not captured, and sort of what is the path moving forward in terms of costing. So why talk about cost? So you can see on the left-hand side, this is the budget in terms of healthcare in Ontario. You can see it rising every year with the projected increases. You can also see that the average annual growth, if you go back to 2011, 2016 at 2.2%, which is expected to go to 4.4%. Just this past year, and probably increasing moving forward. In a report out of Forbes magazine, there was an article, and it talked about new medical technology, and probably incorporating medications in that is really probably responsible for 40 to 50% of annual increases in cost. So we know that new technologies are going to generally add cost, and this is not a new concept. We often see with the introduction of new technology, and this was from an article back in 1994, where they looked at laparoscopic cholecystectomy, and in their analysis they found that hospitals would be losing an average of $443 per patient in those patients who underwent a laparoscopic cholecystectomy compared to the traditional open procedure. We obviously can fast forward now over 20 years later, and laparoscopic cholecystectomy is a standard of care in the management of gallbladder disease. Then you have improvements in existing technology, and that's probably even more challenging because you have a technology that's already there. The best example in laparoscopic surgery, the use of bipolar instruments. And when the vessel sealing devices, the disposable ones, came into the fold, you actually saw quite an increase probably in utilization of laparoscopic surgery, and the costs were somewhat absorbed. So every month we have meetings and we go over our budgets, and I invariably get told your service is well over budget, and I say sorry, and then next month we do the same thing and I say sorry again, and that just keeps happening over and over again. And so when you have so you say small improvements to technology that's already there, those costs tend to be absorbed. I was trying to think of something at the scale of robotic surgery, if there's other examples in our healthcare system, and I think probably if you looked at drugs and how drugs get incorporated in the healthcare system, that's a whole other avenue. But one that I think may be a bit more applicable is intensity modulated radiotherapy. So for those of you who are not familiar, and certainly I'm not a radiation oncologist, but this was sort of seen as a bit of a more precise way of providing radiation therapy that would reduce the side effects of unwanted radiation to normal tissue. It started at UHN in 2004, And when it began, it did not have level 1 evidence. And as a matter of fact, to this day, and I was speaking to my radiation oncology colleagues, the amount of level 1 evidence for the use of IMRT is somewhat limited. There was one study in gynecologic oncology just in 2018 that did show a benefit. But there's no question that it comes at a cost. There's an increased cost in the use of this technology. Some of the values, they're small, and if you can see them, but they're in the thousands of difference. In the study of gynecologic oncology 2015, what they ended up showing as a result was to say that it was not really cost effective in the early chronic phase, but became more cost effective with time. And I want you to sort of have that in your head, because I think that's the challenging part in establishing good data of how beneficial this technology could be. These numbers are also pretty big. You look at the treatment costs of these patients in the tens to 20s thousands. And I think it brings the point to the differences in system. And I think if we're going to talk about cost, we have to bring up the idea and understand some of those differences in cost. So you saw this schematic earlier on in Jason's presentation. But if you kind of look at it, you'd say that in the United States, there's one robot for 97,000 people compared to one for 815,000, and obviously in Asia, 1 in 6 million. So there is definitely something driving the US market, which doesn't exist in other places, certainly not in Canada. And there is a fundamental difference between the US system and our system, and in their hospitals, they have an incentive to do more. Bringing in business brings in revenue. Of course, there are challenges and they have to be efficient, but the model is generally based upon that. And that's why you saw this explosion of robotic surgery in the United States, because every hospital wanted to have one. It probably also was the reason you had complications, because you probably had some people that had no business being on the robot, but their hospital got one and got them on it. In Canada, and I put in quotations, we have no incentive, and I say it in quotations, because we do have incentive. We all want to do better for our patients, but we don't have a direct link financial incentive. The backbone of the delivery of care and of funding to hospitals through a base funding model. Now that has changed, and in oncology we do have per case funding. But when we have these meetings and we see these values, we know that the actual amount that we receive does not account for the entire cost of the care of that patient. And so invariably, it's not that we have these oncology funding and we say, oh great, we're going to be way ahead of the game. We're sort of limited in what we can do, and it probably does not actually cover the cost. And then if you do overperformance, you'd say, okay, we want to do really, really good. In the past, you didn't even get paid at 100 cents on the dollar for that. So that's not really a system which will be incentivized to sort of bring in and do more cases. We don't really get a bonus at the end of the year if you have an institution to say, you know what, you actually treated 30% more patients than you did last year. I realize it cost you 10% more, but actually you're 10% over budget. And that's the discussion really that is had. So that's a fundamental difference. This is some data in terms of costs and differential costs in robotic oncology for gynecologic oncology. The first was a paper out of Bell, and this was actual data. You see the numbers are small, but you can see that the most expensive mode of delivering the care is through laparotomy, with the least expensive being laparoscopy and robotic being in between, but certainly closer to the laparoscopy in their setting. I think this is an important point to bring up, because when we talk about robotic surgery, a lot of the benefits that we describe have to do with minimally invasive surgery and with laparoscopy that is possible in certain disease sites, and in fact, in many places was a very important way of delivering the care for patients. And so when we look at data in gynecologic oncology, we always have to compare the three. We can't compare open surgery versus robotic surgery because there is a strong laparoscopic arm. When we have the other study that I showed here, this was a modeling study, and they tried to do it based on societal perspective or hospital perspective. And you can sort of see the numbers. But, you know, I think what really dawns to me when you look at these numbers, we're not looking at numbers of $5,000, $10,000 difference between the delivery of care. They're in the, you know, $1,000 to $2,000, $3,000 range. And when you look at the entire cost continuum, and when I say the entire cost continuum, that really is focusing on just the immediate care, not that aftercare that I talked about. This is some data from Canada, the Jewish General in Montreal. And what further complicates the story is to say that you have a center like the Jewish General. This was a study where they looked at what was the cost per patient while they were in hospital, and you can see after they implemented their robotic program, their cost per patient went down by 59%. And that's really all attributable to the black part of the pie graph that was through how they did open surgery. So the shaded area, which was the minimally invasive, they did virtually no minimally invasive surgery for gynecologic oncology at the Jewish General. And when the robotic platform came into play, suddenly their minimally invasive rates became very high. So people who are advocates of laparoscopic surgery say, well, we can achieve similar benefits. And I think we would probably all say at the end of it, it doesn't really matter how you accomplish it, but you have people who just can't accomplish it laparoscopically. So if the robot is the tool that will get you into minimally invasive surgery, then that's a very important part of the care continuum. We embarked on a study called the GOC2 study, and that was initiated in 2011. We knew back in 2011, now, did I think we would be in the exact same position now 8 years later? I was hoping we'd be a little further ahead, but the reality is we're not much a different position than we were back in 2011. So we had some funding. We applied through the Ontario Innovation Grant, and we had some other, we sort of pooled some funds together. And we said, let's try to do this right. If we're going to do this once, let's get all of the necessary data. And so what we wanted to do was we want to look at the perioperative outcome of the patient. We want to look at quality of life metrics and also the costing element, which would include a longitudinal element, including cost effectiveness, back to work. Unfortunately, we realized that for this scope of this type of study, there was no way we're going to be able to accomplish all of that aftercare assessment because it just is too expensive. And so we had to really focus, like a lot of studies do, on just the immediate care. So we enrolled 520 patients across Canada. This was not a randomized controlled trial. At the time, only 3 of the centers had a robotic platform, and we really allowed people to sort of do the surgery in their best expertise, whatever that way was. We wanted to initially not randomize, but have an equal cohort of open and minimally invasive, and we had to stop the study early because we realized we were never going to reach it with the open surgery. And some would say that in itself was a conclusion of the study, to say with the advent of robots, because by the end of the study, most of the programs had robotic platform, that we just weren't doing as many open surgeries before. We were never going to get there. We did have enough, though, to do some analysis. We published the first paper on the quality of life and showed that the minimally invasive surgery quality of life benefits extend even to 3 months. That was never previously shown, both with the robotic platform and laparoscopy. I'm going to focus on the costing element of the study, but to show you that we did have some comparisons to laparoscopy, and the women that had robotics did have larger BMIs, and the rates of conversion you can see were 8% in laparoscopy and 3.6% in the robotic. What we wanted to do as part of the study in a prospective fashion was to actually capture every single cost. So we captured every suture, we captured every disposable, we captured Band-Aids on the floor, CT scans, and wanted to incorporate it all to have a real-time cost. And this is the difference that we found, and interestingly, the results were very similar to what Dr. Bell had shown back in 2008. The most expensive way to deliver the care is through a laparotomy. Laparoscopy, if you can do it, is the cheapest, and robotics, again, falls somewhere in between. In terms of women with BMI of over 40, we've heard a little bit about that. There was no statistical difference in cost among the 3 modalities. But if you look at the numbers of cases, and again, this was not a randomized trial, but you see that more than 3 times the amount of patients had robotic surgery in this size than either laparotomy or laparoscopy. And so, again, it's nice to say that laparoscopy, and I think if it can be accomplished, you'll achieve a lot of the similar goals. This is just talking about outcome measures that we have available today, but only if you can actually accomplish it in that way. I'm not an expert in terms of prostate data, and I'm not going to talk about it, but obviously there was a report out of Alberta, or an assessment in 2017, and they introduced the concept of quality with robotic surgery, and they came out with a number of 42,000 of quality-adjusted life years. In Canada, anything under 50,000 is deemed to be something that should be considered, and obviously it showed superiority in a number of different elements. This was an article in 2018, and what they really showed is that if you look at all of the papers in terms of costing with robotics, the evidence is poor. We don't have good longitudinal data. In a lot of studies, they don't incorporate all the costs. Most of them were modeling studies, and ours is one of the few that has a prospective, sort of robust, capturing each element cost. There was also an article by Alan Detsky, and it was really, again, speaking to the fact that we're not encompassing all elements of assessment in terms of cost effectiveness, and we have to be careful to interpret cost effectiveness with the limited data that we have available. This was one study that was published in 2016. Again, it's prostate work, but they attempted to sort of try to tease out some of the downstream effects, and what they showed is if you do that there was a benefit to the robotic platform, to the open prostatectomy. Again, this was using Monte Carlo modeling, and I do always say if it takes you longer to understand how the model works than the results, then it's not going to be something that's easily translatable to all. But I think the message is there to say that we need to do better. We want to capture all four of these in the delivery of healthcare. We want to improve the patient experience. We want to have a population health mindset, sustainability costs, and provider satisfaction. But how are we going to capture these long-term benefits in terms of medication use, productivity lost, caregiver productivity loss, long-term complications? When we think of studies in the future, we're going to have to incorporate these elements because they're critical. I thought I would just put this slide up just to sort of say how does a top academic center match up to some of the other American centers. And the one thing you'll see is outpatient and inpatient. And, I would propose that we can probably, even at UHN, where we have definitely pushed the envelope, do better in terms of outpatient for surgery. And you can see some of these other centers, these are large centers, and how they've been able to accomplish that. And probably the robot has had an impact with regards to that. So as I've just sort of closed out here, the real question is who pays for innovation, and what's going to be the most effective way to pay for it in a single payer system. As you've heard already, the majority of the robotic programs in this country have been sustained due to philanthropy. So that means fundraising at the hospitals, they collect money and they pay for it. Alberta is the one province that is unique in that all of the costs related to robotic surgery are funded through the government program. In Ontario, there is a somewhat blended model. You have a couple of hospitals that have some support that come through the hospital budget, but for the most part, the robotic programs are completely reliant on philanthropy. It becomes complex when you start to have programs that are 100% reliant on philanthropy. And, I hearing Joan's talk and her 10-year vision, if we go back 10 years from the initiation of the program at UHN, that was 2008. That would have been in 2018. And yet we're still really having the same challenges that we had back in 2008. And so we have discussed what does closing the program look like. And what becomes interesting in that discussion is you realize that although this program has been sustained with philanthropy, it actually has taken money and saved money in the actual global system of the hospital that doesn't really get counted for on a day-by-day basis. And so in a very kind of crude assessment, and the numbers aren't perfect, we actually identified that if the program was kept open and supported for by the hospital, that the cost would be in the range of $1.7 million. And if we actually shut the program down entirely, the cost of the system would actually be $1.3 million, factoring the changes in what would happen to all those patients that are currently being managed by the robot. So with all this said, I don't think anybody in the room has any great ideas. I certainly don't, but there are some potential models that we have to look at moving forward. I certainly, having been a robotic user now for 11 years, have concerns that complete reliance on the philanthropy is not a sustainable model. And I think many of us feel the same way. So we're either going to have some kind of partnership between hospital foundations, governments, or the hospitals themselves. We are somewhat fortunate, I think, in Canada that we do have a very robust philanthropy network. And I don't think there is... I think there's a positivity to philanthropy paying for capital costs. I think the challenge that we have is in those maintenance and operational costs. Maybe we have to look at this entirely differently. Right now, we've had models where hospitals decide I'm going to have a robotic program, but maybe we need to have robotic programs sort of in geographic locations and sort of self-alone centers where people from Trillium can go and operate there, and UHN can go and operate there, and it's not sort of a single hospital model. One thing we know, and you can see the graph on the left-hand side, the less cases you do, the more expensive the whole thing is. The more cases you do, the less per case the whole thing costs. So the worst thing a program can do is spend a lot of money, build a robot, and then do very limited cases on it, because that is by far not ever going to be a cost-effective model. And so maybe having sort of surgical hubs is the way to think about it. Or obviously having to allow some other way to generate revenue into the system to pay for it. And people have talked about patient paying systems. Certainly in our field of gynecologic oncology, we think that would be a challenge. The patients that often are afflicted by the diseases, certainly it would be very difficult for them to pay. But I think at some level in the discussion, we're going to have to land on something, but the status quo probably isn't the way to go. I do think, this is my last editorial slide, to say that if we want to remain at the forefront of surgical innovation and implementation, Canada is going to have to figure out a way to pay for it. This is not unique to robots. There are new innovations and technologies, new drugs that are coming every day that are getting more and more expensive. We're going to have to figure out what it is. Either the patients are not going to get it, and we'll have to tell the public and say, there is technology, but you can't get it because of our system, or we're going to have to figure some other way to pay for it. But I think that's important. And waiting for level 1 evidence for all things when it comes to innovation will really deny patients the benefit of new technologies. Thank you. So with that, I'm going to stay up here and introduce our next speaker. Dr. Randy Fagan began his career as a urologist and became one of the highest volume robotic surgeons in the world, treating patients and educated surgeons from across the globe. In 2009, he became the senior medical advisor for the largest robotic surgical company in the world, Intuitive Surgical, where he developed programs, analytics, and a process for healthcare economics and programmatic performance in the delivery of Da Vinci robotic surgery. In 2011, he left clinical practice to join the Hospitals Corporation of America, where he currently has responsibility over driving strategy, value, market share shift for a range of surgical services that includes robotics, orthopedics, neurosciences, spine, general surgery, and OR infrastructure. I somehow feel less adequate in my job. Please, Dr. Randy Fagan. Are you on this one? So let's just, let me help you out here.
Perfect. Thank you all. It's a pleasure to be here. I've been good friends with Danny Minogue since, about 15 years ago when I was doing surgery, and I really appreciate the kindness of his invitation to come here and speak with you all. As the prior speaker mentioned, it's been an interesting journey for me along my career, from kind of surgeon to the vendor side to Hospital Corporation of America. Just as a little perspective on what I'll be sharing with you, HCA, or Hospital Corporation of America, is the largest healthcare management company in the world. We own 185 hospitals across 45 different cities, including the UK. About 141 ambulatory centers, 130-ish urgent cares. We own 4,000 medical practices, although there are 42,000 physicians who utilize our hospitals who are not employed by us. We have the largest graduate medical education program in the entire United States, and it'll be doubling over the course of the next 3 years. We are also the largest user and consumer of robotic-assisted products in the world, and we are a for-profit company. So how does that work? Let me kind of share with you the way that we view robotic-assisted surgery, not just Da Vinci, but robotics in general, and why we believe it's important for our patients, for our hospitals, and for the communities that we serve. So if we look at what is robotic-assisted surgery, robotic-assisted surgery to me really isn't about mechanics or about vision or about precision. It's really about bending the value curve of how we actually demonstrate value to our patients. If we look at where it's been and where it's going, Da Vinci is really kind of where it's been and a lot of where it is currently. And the value proposition there really was around vision, precision, and the ability to enhance access to the abdominal cavity. As you've heard a number of folks speak to, the ability to allow a larger percentage of patients to be candidates for minimally invasive surgery. So although, as you heard the last speaker state, laparoscopic surgery and robotic surgery often have equivalent outcomes in a lot of studies, the number of patients who can have minimally invasive surgery as a result of robotics has in aggregate increased the number of patients who are able to experience that minimally invasive approach. So this has been all about access, essentially. Of recently, they also started to enhance a lot of the technologies that were available inside of the robotic system. So advanced energy that allows you to cauterize and cut at the same time. Staplers that actually sense the tissue that you're stapling so that you don't staple too much or too little, improving the safety of that device. And then table motions that as you're actually trying to use gravity as your retractor, you can safely do that in real time during the operation. But that's kind of where it's been. Where it's going is a little bit different. Where it's going really is around imaging, navigation, education, and analytics. That's what I want to speak to. The imaging side is actually really fascinating. This is really around how do we give our surgeons access to information they otherwise don't have access to. Instead of them using intuition, how can we give them knowledge they don't otherwise have? So anatomy, pathology. Let's talk about anatomy first. ICG, Intuitive Surgical, introduced this. It was the first foray into providing surgeons with access to images that they otherwise wouldn't have. The image on the left-hand side is just a picture of the pelvis, the ureter sitting down there. For hysterectomy, one of the most common complications of a hysterectomy is injury to the ureter, especially for folks that have had prior operations for gynecologic, for urologic, for colorectal surgeries. Injury to the ureter is unfortunately more common than we would like it to be because it's stuck in there and it's hard to see. With ICG and a laser light on the camera, it's literally right in front of you. The ability to provide surgeons, rather than intuition, I think I know where it is, I know anatomically where it should be, show them exactly where it is in real time. This is also being experimented with on the nerve side. This is not yet ready for prime time, but similar to other organs, the ability to actually inject an agent that's selectively taken up by nerves and then use laser light or infrared light to excite it, the manipulation of light inside the abdominal cavity, and allow surgeons to have visualization that they otherwise wouldn't have with just their naked eyes, or any magnification for that matter. Image overlay, also coming to an operating theater near you in the very, very near future. The ability to take CT scans and images and overlay them on top of real anatomy. For something like renal surgery, which is the image here with the Da Vinci console, overlaying a CT scan so you can actually see where the vasculature is before you dissect that delicate area. This is not yet available for renal surgery, but it is available for spine surgery. There's actually virtual reality, augmented reality headsets that spine surgeons can wear, and utilizing fiducials, you can kind of mark spots on the spine. The computer will match up those spots on the spine to the CT scan, and looking through the skin, you can see the patient's spine. And as you look up and down that patient's skin, you can literally see their spine, you can see their anatomy, and you can operate in a minimally invasive fashion, literally using X-ray vision. Available today. Actually, there's two more. There's a single company, Augmentus, that offers it now, and 2 more companies soon to come. Pathology, this is very interesting as well. So when we do cancer operations, we can't see the cancer. We see inflammation or stuff the cancer causes, but we can't see the cancer cells unless you light them up. And this is very, very real. There are injectable agents that are selectively taken up by the cancer cells. And again, using infrared or laser light inside a closed abdominal cavity, you can manipulate light in a way that the surgeon can literally see the edges of the cancer they're operating on. This is something you can't do with open surgery, that you would have a very challenging time doing with laparoscopic surgery. You need a computer interface. You have to have a computer interface in order to do that and allow the surgeon to use that in real time for their decision making. Navigation, Synaptive Medical, out of the proud country of Canada, Toronto actually. Cameron Pyron, the founder of this company. Synaptive Medical is in the cranial space. They have a number of very interesting technologies, one of which is really around the ability to provide surgeons with the best view of whatever they're operating on at every single moment. One of the challenges in surgery is providing the optimal view depending on where you're looking. So this uses these fiducials or these little markers on the robotic instrument. This is intended for cranial surgery where it's very difficult to get access to see exactly what you want, and it uses a high magnification lens and a robot to actually line up the camera with exactly where the surgeon's instrument is pointing, not just where it is in space, but where it's pointing to, giving the surgeon the best view he could possibly have of the anatomy he's trying to operate on. Computer interface augmenting a surgeon's ability to do a better job in the operating room. Also by Synaptive Medical. This is called Bright Matter. This is actually, again, using computer software to take a CT scan and using knowledge of anatomy, be able to say, I know if I create an entire map of a nerve, when a nerve begins and a nerve ends, based on where it begins and where it ends, what that nerve's function is. And then based on functional areas of the brain, color code it. And then based on those color codes, know which areas of the brain control which functions and which ones you need to avoid for a brain tumor operation. If you're trying to go after a tumor in the brain, the name of the game is not just getting to the tumor, but it's getting to the tumor without causing collateral damage. And the collateral damage isn't just caused by the stuff you touch around the mass itself, it's caused by getting access to where the tumor is. They're not sitting at the surface of the brain, they're down inside. So sometimes the best path to get to a tumor is not the most direct path. It's the one that causes the least amount of damage to surrounding tissues. And using the Bright Matter technology, surgeons can literally color code. They can then strip away sections of the brain that they believe are not as important to preserve, gain access to just those areas that they want to see, and create a map for themselves. They can literally do the operation before they do the operation and figure out their path of insertion for getting to the tumor, and then the robotic system will guide them directly down that path. That idea of navigation is really transforming musculoskeletal surgery. We're seeing it in hip and knee as well as in spine. There's 2 companies in spine that have kind of the market share leaders right now. One is called Globus. The other is Mazor, which is owned by Medtronic. This is an O-arm. It's doing a real-time CT scan of a patient in the operating room. That CT scan then gets loaded into a computer. Once that image is loaded in the computer, the surgeon places those fiducials, those markers on the patient, so the computer system knows where the patient is. He then goes over to the monitor and maps out the operation he wants to do. Literally does the operation on the computer system. This is a fusion procedure where they put screws in to kind of fuse to the lumbar spine together. He maps out where that goes. He wants to make sure that it's got a good purchase inside the bone itself, especially if it's thin or damaged bone. You want to make sure you've got the right angle, make sure that you're not damaging nerves, make sure you're not impacting things around you, get the exact trajectory that you want and the exact depth that you want. And then the computer system guides you to the exact position you want to do it in. You can then do it percutaneously percutaneously. One of the greatest complications or problems with spine surgery and reasons why the recovery is so long is the open approach. It's getting access. It's stripping the musculature away from the spine and getting access to the stuff you need to get to. If you can do it percutaneously, you avoid all of that damage. And you can do it with improved accuracy. So fascinating, the ability to actually do real-time surgeries before you do the surgeries. You can only do that with computer assistance. You can't do that open. You can't do that on a laptop in your office. You have to do it merging the virtual with the real in an operating room real time. What about simulation and remote learning? You know, the C1, Do, and Teach One model that was around for at least my training is really something that should be dead by now. We shouldn't have to let surgeons do a surgery for the first time on a patient. We should be allowing them to do a surgery for the first time in a virtual environment. This started with just letting them kind of move around pegs and ropes and things inside of a virtual environment. But this has progressed substantially. There are now real-time simulation exercises where you can have somebody do a hysterectomy. You can make it a really big uterus. You can make it bleed a whole bunch. You can do the anastomosis where you hook the bladder back up to the urethra for prostatectomy, one of the more challenging aspects of the operation. You can make the urethra more friable so it's going to tear if you pull on it. You can literally have surgeons learning to do surgery in a virtual environment before they do it in an actual environment. This is just better for our patients. This is a better way to train people and a better way to actually deliver care in our hospitals. What about remote learning? You know, when I wanted to learn from an expert, I needed to physically go to that expert. I needed to hop on an airplane and go to their operating room, or go to a lecture where they showed video clips from their favorite operation that wasn't their hardest operation, and they would brag about the pieces that they did exceptionally well that really aren't representative of all the things they do every day. To get a real feel for what somebody's actually doing in the operating room, you have to be in their operating room. But there's no reason that we have to be in the operating room. I mean, for God's sakes, I FaceTime my daughter when I'm not in town. My son texts his friends. He's on Skype with them when they're playing games. Why on God's green earth are surgeons getting on airplanes to go learn from other surgeons? They don't have to. There's now virtual platforms. Intuitive Surgical is only one of them. There's a number of them out there that allow surgeons to log in to other surgeons' operating rooms to see not just what's happening inside that surgeon's view of what they're doing, but also what's happening in the room. What's happening in terms of workflow? What are the nurses doing? How are we delivering care? And how can I replicate that? And then just interact with that person, actually communicate with the team and the surgeon in real time. And that can be done bi-directionally, where you can have an expert logging into a novice or a novice logging into an expert. This is just transformative in terms of the way that we educate our surgeons after they leave our graduate medical education programs and enter practice. You know, we all, whether we like it or not when we are surgeons, if you're operating, you have entered a field that requires a lifetime of learning. That means you don't stop learning when you leave your residency. We have to be able to continue to train our surgeons in a more effective manner. Computer assistance is the only way that we can do that. So analytics, you know, one of the things that surgeons are incredibly bad at is analytics. You know, outside, candidly, of academic centers that have entire infrastructures to manage information, surgeons do a very poor job in the private practice world of capturing objective, quantifiable information about their performance and actually utilizing it for improvement. They just don't. It's hard, it's subjective, it's manual. But when you introduce a computer interface, you can start to change some of that. And when you're doing it in a computer-assisted environment, you can now capture data on the operation that you're doing, not just the movements you do, but the operation you're doing, where you place the screws, how it looked inside when you did the mapping, what does it look on the CT scan afterwards. Mirror that up to post-acute care information. There's patient-reported outcomes measures that you can capture electronically from patients. Our ability to capture electronic information passively is transforming what used to be kind of how fast you did an operation. Surgery is not a race, so fast is not the answer. But it's allowing us to capture passive information and using it for our improvement. Apple, we were just up at the Apple campus, a bunch of our folks from HCA talking to their executive leadership team around their use of passive collection of information through their wearables. There are 85 million Apple devices out there in the world today passively collecting information on you. And I don't care if you've got an Apple Watch or you've got an iPhone or you've got an iPad, it is collecting information in real time on everybody. It knows where we go. It knows how many steps we take. It knows if we fall. It knows if we decelerate rapidly. And if you have an Apple Watch, that's a recent one, it actually knows your EKG. It knows your heart rate. It knows your blood saturation. And actually now they're looking at the ability to capture through that Apple Watch and infrared light blood glucose levels non-invasively. The ability for computer assistants to passively capture objective quantifiable information and allow us to use it in real time to improve the care of our patients only exists through computer assistance. It's expensive. It costs money. It's just the way it is. So let's talk about the cost of innovation. Are robots and computer-assisted devices expensive? Yeah, they are. You go to the mall and you grab a Swatch for $35. You go to the Apple store and you spend $1,100 on an Apple Watch. I don't care if you talk about a $1 million robot or an $1,100 watch. Technology is expensive. But let's talk about robotics. Do the instruments cost more? Often, they do. If the procedures take longer? Sometimes. I'll talk to you at the end about some procedures and some robotic assistants that are actually reducing the operative times in a very, very objective, quantifiable, and repeatable way. Operative time is a metric of comfort and skill and experience. It has nothing to do with technology. People take longer in robotics when they're learning something early. So does a resident who's doing his first cholecystectomy. It just takes longer when you're earlier in the learning curve. But does this mean that these procedures are more expensive? And the answer is actually not necessarily. The question is the way that we capture cost and what do you view as the episode of care? In the United States, we have had a number of things thrust upon us by CMS, our government healthcare system. Bundled care, value-based care, paying us for an episode of care as defined by the government, and then it's up to us to figure out how to spend money, and either we owe them or we get extra. It's really that simple. It's a bulk of money, you spend it as you want it. And they're doing that for about 1,000 different episodes of care. They're defining episodes from the acute episode, at least for surgery, the acute episode to 90 days afterwards. But let's just talk about the acute episode for robotics specifically. This is for colon resection. We did this for HCA. This is over, we have 47 different ways that we capture direct variable costs inside of HCA. We did this over a 5-year period of time. And what we found was for the robotic yes categories, these are robotic assisted surgeries, our MediSurg supplies, our device supplies, and our OR services were about $2,100 more expensive, which amazingly actually goes straight along with the speaker that came right before me. Very, very similar. What we did find also, though, is if you look at other costs, pharmacy, ICU, room and board, laboratory, blood administration and storage, recovery room, respiratory services, our costs are about $2,300 less. If you then take into account the fact that when we do these cases through a minimally invasive approach, the patients leave the hospital 4 days sooner and they spend 2 less days in the ICU, and the fact that, similar to the last speaker, robotics is enabling minimally invasive surgery. What it's stealing from is not laparoscopy. It's stealing from open surgery. So where we used to have 65% of our colon resections being done either hand-assisted or open, if we move to robotic assistance, that number goes down to about 35% across HCA. A larger percent of patients having a truly minimally invasive operation. It's reducing the cost of care for the episode. Although the time in the operating room may be more important, may be more expensive, the cost of the episode is less. I want to talk to you before I go into a little bit more here about one of the platforms that I don't have a video on. It's extremely new, and the videos they have seem a little bit too self-promotional for me to put on there for you. So let me just describe it to you. Both Intuitive Surgical has a platform as well as Auris, which is another company out there. It's a pulmonary robotic system. Here's the problem they were trying to solve. The problem they were trying to solve is when a patient has a 1.5 centimeter or less lung nodule, their likelihood of having a positive cancer biopsy when it's actually cancer and you go endobronchially is 65%. So 65% of patients with an actual cancer that are 1.5 centimeters or less get it positively diagnosed endobronchially on their first try. If you go transthoracic percutaneously through a CT-guided approach, that number goes up to 92%, but 1 in 5 patients end up with a pneumothorax. Not great. So using robotic assistance, what they've been able to do is take a CAT scan, marry it up with that patient's actual body, and in real time, marry those things together. So the surgeon, when they put the scope down that patient's trachea into their bronchial tree, gets, and I mean literally, a Waze map, where on that person's bronchial tree, it shows a blue line that goes right and left at every single branching point. You think about a bronchial tree, it's literally like a tree. You're inside, you got to start at the trunk and make your way all the way out to one of the little leaves at the end. That's hard and challenging to do, and these interventional pulmonologists use CT scans in multiple directions, their knowledge of anatomy, to do these procedures in about 1.5 hours to 2 hours, typically. If you have a Waze map to get to that tumor, it takes about 15 minutes, and your positive biopsy rates go up to 95%. This is actually happening. There's about 45 of these across the United States currently, and growing. What's the benefit? What is this doing for our patients? Well, it's actually downstaging our patients. What we're finding is, instead of 40% of patients being candidates for surgical cure at the time of their initial diagnosis, 50% of patients are candidates for surgical cure at the time of the initial diagnosis. That means that few of our patients are actually needing radiation or chemotherapy, and a greater percentage of them are cured with surgery alone. Not only is that massively beneficial to our patients, but it's massively beneficial to the healthcare economic equation of lung cancer. It is truly transformational, and it cannot be done without computer assistance. When we talk about the value of intelligent surgery and bending the curve, we have to think beyond the actual cost of the equipment. We have to think beyond the cost of the stuff that we use, and think about the episode of care and the value we deliver to the patients. What's happening today literally is transformational. And it is something that's going to continue, and it's just a pleasure and a privilege to be able to be a part of it at the scale that our company is. So with that, thank you very much. Appreciate your time.
Thank you very much. I think back to a talk that I gave probably about 10 years ago when I just started on the robot, and it took me about 2 hours to put a slide together where I took a CT image and say, what if we could overlay this? And this is probably coming in the future, and it's amazing to see that we're pretty well here, ready for prime time, and it's very exciting to think of what's happening moving forward. Okay, we have our last speaker coming up. I'll introduce you while you're connecting here, so we'll be efficient. Well, Hannah is a thoracic surgeon and associate professor in the Department of Surgery at McMaster University. He focuses on treating patients with lung cancer, esophageal cancer, and mediastinal tumors while running the highest volume robotic lung cancer surgery program in Canada. Dr. Hannah and his team are innovators whose research focuses on robotic lung cancer surgery, artificial intelligence applications, quality improvement in thoracic surgery, and he's going to talk to us about augmenting the curve beyond human capabilities. Thank you.
Thanks very much for the pleasure of being here with you today. And thank you for the segue into lung cancer, because this is really what I'm going to be talking about. I know it's late in the day, so I won't belabor the robotics topic a lot. These are my disclosures, but most importantly, I will be showing you videos and procedures that are not yet approved by Health Canada. They're all experimental, so a little bit of a preview of the future. We've noticed today, robotics is a divisive topic. You can fill a room with patients or surgeons and researchers and educators, and you can find many reasons why we should be a robotic nation and many reasons why we shouldn't. Namely, it's expensive, it's hard to implement, but it also gives the best to our patients. So it is a divisive topic, and if you believe that the adoption of robotic surgery is necessary for the future of surgical care in Canada, raise your hand. Good, divided room, 50-50, welcome to Canada. But we don't really feel the same about immunotherapy, which is the newest thing in lung cancer, but is extremely expensive. CyberKnife or IMRT that was mentioned earlier, we don't question that, and we don't certainly question bariatric surgery, which is extremely beneficial, but also expensive programs. And so I'm not going to talk about robots, because we don't want to be divisive this afternoon. Instead, I'm going to tell you a story of a little program made in Canada, not funded by private healthcare or insurance, but by public funds. So this is the innovation vector of surgery. At one point in time, we used to do open surgery, and then we discovered minimally invasive surgery. In thoracic surgery, my specialty, open surgery is done by thoracotomy, a big incision in the chest. A minimally invasive surgery is done by video-assisted thoracic surgery, VATS. And, you know, when you look at it, it's very easy to see that thoracotomy is morbid, whereas VATS is small incisions in the chest. But more than that, there's less pain, less disability, shorter hospital stay, less complications. You can do it by the camera. We forgot the concept of big surgeon, big incision. It became, can we do things smaller and better to allow for better recovery? And so how do we innovate in surgery? We think less. Small incisions, less pain, short hospital stays, less complications, lower mortality. Everything is smaller, and there's value in being smaller or less in surgery. And so when we got to VATS, that was our big break. Where do we go from there? So we were like, okay, VATS requires 5 incisions in the chest. Why don't we do it with 4 incisions? And that was 4-port VATS. And then one skilled surgeon said, I can do it through 1 incision. And that was uniportal VATS. And then the third one said, well, I don't even have to go into the chest. I can go in under the xiphoid, to the belly, into the chest, and do the operation there. So we started trying to innovate by doing less incisions, smaller incisions. And if we keep that train of thought, our next big break is going to be no incisions. We're going to start radiating everybody. We're going to stop doing surgery. Because really, what is the natural evolution of smaller and smaller? Eventually, you get to 0. But we know that that's probably not sustainable. Surgery is important. At some point, you need to take out tumors of people. So this strategy of innovation, of thinking less, is not going to work for us on the future. So I would challenge us to say that to truly innovate, we have to think more. We have to flip the innovation vector back to something that's bigger than thoracotomy, when we can do things we cannot do through a big incision, something beyond our big incision and our human hands. And this is where I think robotics comes in. You had a very nice preview of this just in the talk earlier by Dr. Fagan, but I'm going to tell you a little bit of what we're doing in the chest. So VATS is very good, but robotics is better. And it's better because of the technology, not because of the size of the incision. You have the 3D magnified high-definition images. You have infrared vision, where you can see green tissue. You have 4 arms instead of 2. You're not relying on your assistants. The robot never gets tired. You can do a 6-hour operation, go for a coffee, come back. The robot's waiting for you. It's not moved. And so that's what you're comparing. And the analogy is you're taking UHN's finest thoracic surgeon and you're comparing them to this guy. You're not comparing the incisions, you're comparing the surgeon. And so if you, as a patient or a surgeon or an academic or a student or a nurse or a researcher or a hospital administrator had the chance to do a project with Superman, would you take it? Great. The rest of us don't believe in superheroes. But what does that have to do with surgery? Well, here's a question of real life. What is the most effective way of retrieving a golden coin from this yellow haystack? Well, really, the most effective way is burn it down, right? You light the thing on fire, it disappears, there's your coin. Or you can ask Superman to use X-ray vision to locate the coin somewhere in the center of the haystack and use their heat vision to burn a trajectory through the haystack to where the coin is, allowing you to retrieve it. That's another way. More expensive, more complicated, but you don't have to burn down the haystack. What does that have to do with real life? You just heard about the little lung nodules that nobody can diagnose. Well, guess what happens to them when they can't diagnose them? They send them to me. And so now I have to find a 9mm nodule in this big part of the lung somewhere. So in Canada today, what's the best way of removing a non-visible, non-palpable small tumor of the lung? Whack it out. If you had a 9mm tumor in your left upper lobe today in Canada, you will lose half of your lung because it's important to get the tumor out. We know it's somewhere in the lung, somewhere in the top half, somewhere in the bottom half. Take that half out, tumor's out. Great. And we've been doing that now, and we're competing on who can do this with a smaller incision. This is the state of our innovation right now. But I challenge us to think, what if we can use 3D reconstruction, overlay that image on a CT scan, superimpose it on the robot, mark it, and remove it with a small area around it, sparing the rest of the lung. This is our vision trial. It's experimental, so don't do this at home. But basically what you do is the green spot is the lung, is the tumor, and the gray is the lung. And you can tell that this tumor is somewhere in the lung, and there's a map to it through the airway, through the pulmonary artery and the pulmonary vein. You take that map, you superimpose it on the robotic console, you have that Waze or GPS map, and then it tells you which blood vessels you have to cut so you can get to the tumor. So here's a branch of the PA that was divided, and then now you're looking at the bronchial tree. The nice thing about this app is when you divide a branch, you click on it, it disappears from your map. So you don't have to worry about it again, because it's gone in real time, and it's gone on your map. Ooh, small blood vessels. If I hadn't seen that, that would have bled like stink, but the map showed it to me, so I paid attention and I burnt it again. And then we get to the vein. We find the vein. Out of the 13 veins that are found in the lung, this is the one I have to cut to get to the tumor. And once I've cut the artery and the vein, that tumor is isolated from perfusion. You can inject anything in the body, it will not get to this tumor because there's no veins and there's no arteries leading to it. Then we find the airway, we cut the airway, and then we inject the indocyanine green dye. And when you turn off the infrared camera, the beautiful green lung is the lung that we managed to save. And the black lung is the lung that is around the tumor that we need to cut. All we have to do is mark that plane between the black lung and the green lung and divide it, and that's where our tumor is. That beautiful green lung that you see would have been whacked out if we didn't have this technology, if we were doing minimally invasive surgery. So it's not about the size of the incision, it's about how much lung the patient gets to go home with after their operation. This person went home the next day, less than 24 hours. So if you had the opportunity to work with Superman at the same cost of a regular surgeon, Superman's not going to charge you more, would you take it? In thoracic surgery, which is a nascent field, sometimes robotics is more expensive than VATS, but when you look at segmental resections, what I just showed you, robotics is actually much less expensive than VATS. And in Canada, when you look at resource utilization, robotics depends on the case. And that's why choosing your complex cases to do on the robot can be beneficial. And the problem with cost, and this has been said today, we see the dollar cost. We see how much we spend on a machine, but we don't see what it does downstream. What are you buying for this money? And namely, in healthcare, we call this cost utility assessment, where we assign a value, quality adjusted life years, quality, to that. And that requires very complex studies. But most of retrospective studies, so you get a big database and you do the Markov analysis or the Monte Carlo, whatever, these complex modeling systems, is just theoretical. To really figure out what the procedure costs, you have to start from zero. You have to do a prospective trial, which was prescribed today. So we decided to first map out all of our expenses in the robotic program in thoracic surgery, adjusting for case complexity. Turns out the robot is $2,000 less expensive than VATS. But you can say, well, this is retrospective data. Great. So we started a randomized trial. Stage 1 or 2 non-small cell lung cancer accruing in Canada, the US, and France. We randomized the patient to robot or VATS. We do not tell the patient what they had. The patients wake up, they have no idea whether they got the robot or VATS. And the reason why is because our primary outcome is quality of life. And this is how you can measure quality of life to do cost analysis. So we know that if patients know they had the robot, they feel great. I got the robot. If they don't have the robot, they don't feel not so great. I didn't get the robot. But when you don't tell them, they actually have to tell you the truth. So we do the questionnaires for a year, and we tell them a year later. And our primary outcome is health-related quality of life that will allow us to determine the real cost of this procedure. So stay tuned. If I get invited again in 2020, I'll give you the results. What if I told you that Superman, who comes at the same cost as a regular surgeon, can actually do a better cancer operation than an experienced surgeon? This is an experiment that we did where we pitted experienced surgeons against a robot. So in the control operation, we would get ready to divide the lung. We'd invite an experienced surgeon in the room to show us where they would divide the lung. We give them the cautery, and they burn the line on the lung. They'll say, please divide the lung here. According to my experience, according to the hundreds of cases that I've done, this is where I would cut. We say, great, thank you very much. Then we let the robot do its thing, and we inject the ICG. And then we actually find the intersegmental plane based on the real anatomy of the blood vessels, and we mark that. And it turns out that there's a big difference between what surgeons think should be cut and what the anatomy tells you should be cut. And this difference translates into a 2 centimeter oncological margin. There's 2 centimeters of tissue around your tumor that you can take more if you had the robot help you figure out where to cut rather than rely on your experience as a surgeon. In lung cancer, this is huge because we're not whacking out half of the lung, but we actually do want a fair margin of healthy tissue around the tumor so we don't leave cancer behind. So this is quite important for us, and that allows us to see better than human eyes. And what if I told you that that Superman that can work with you and be cheaper and can do a better cancer operation can actually teach you better than your surgical mentor? Passive recording analysis of data, which was just mentioned, you can run the videos that you get from all your robotic operation through a deep learning algorithm, and the AI will pick up on the hand gestures that are the best ones that will give you the best suture on a prostatic, on an anastomosis during a prostatectomy. And better yet, you can take those videos, run them through the deep learning algorithm, and then correlate them with how the patient's done. So you tell the machine, these patients did very well. These patients did not do so well. Please look at the videos, tell us what the surgeon did. And it'll tell you that you used this suture or that suture, or you started on the right, you didn't start on the left, or there was excessive torque on the tissue. It'll tell you what to do with your hands so that your patient can go home earlier. And this is something we cannot do as humans. And what if I told you that all of this was actually true? And the numbers don't lie. So I can tell you a big story about my numbers, but the numbers can speak for themselves. And this has been shown before, but again, I think it's worth highlighting. In 2004, when we had no robotic surgery, lung cancer in the US, mostly, more than 65% was done via open thoracotomy. In 2017, the red, which is the open thoracotomy, has shrunken markedly, but the green, which is VATS, has not increased. So all the gains that we've had in minimally invasive surgery in the last decade have been due to robotics. And that can only tell one thing. We can do with a robot things that we cannot do by VATS. It's not because our surgeons don't know how to do VATS. They do. Every single thoracic surgeon trained in the last decade will do a very good VATS operation. But there are things we cannot do by VATS that we have to do with open surgery that now we can do with the robot, and that's why the number of thoracotomies has gone down. So, have you used your iPhone today? Or have you taken a flight recently? Or have you driven any car with any safety automatic braking system? Or have you Googled something today? Or have you gone on Facebook or maybe used your credit card for a coffee? If you have, then you are actively enhancing your life with augmented technology. But for some reason, when we talk about robots in our health, this is a concept that we cannot understand or grapple or accept yet. And so I hope that by this brief story, I was able to put us on a crossroad. We can be the people who sit in a room and find 200 reasons why robotics is expensive and complicated and we cannot have it, we don't need to have it, we're good without it, or we can be part of the generation that invents the future. And I think that's a question that's for every one of us. So thank you very much for your time.
Thank you very much. That concludes essentially our formal presentations, and what I'd like to do is bring up to the podium here my colleague and friend, Dr. Tony Finelli. Tony is the Chief of Urology at the University Health Network and Associate Professor at the University of Toronto. He's the inaugural GU Oncology Lead for the province of Ontario. His clinical practice focuses on minimally invasive surgery and robotic techniques to manage urologic malignancies, and he is internationally recognized for his contributions in the area. Dr. Finelli's research focuses on identifying gaps for care in urologic oncology and designing knowledge translation strategies to overcome these gaps. Tony, and I think you're going to invite up a panel of all the speakers.
You're on there.
Okay.
Thanks. Thanks, everyone. Thanks for staying. Hopefully we'll have a good dialogue here. If Marcus, maybe Joan, some of our previous speakers can come up. Randy? Yeah. Is there a way, maybe this can go up? Yeah. Because we don't need that. Jason? Superman, where are you? Come on back. Thanks.
I'm just gonna move the furniture a bit, redecorate.
Joe. We're good, we're good. Yeah, are there microphones? Because I'd love to also open up the discussion to the audience if there's any questions you want to ask. I know where I'm going to go with some of the questions, and I think I'd like to start with Jason. As you know, Jason's our program director, and I think one of the aspects of robotic surgery that's a challenge is where we're going in terms of how do we train our residents, how do we advise our future trainees in terms of employment now that we're in this conflicted state in Canada relative to most jurisdictions in the world. Jay?
Well, I think, sorry, part of it is, you know, the healthcare landscape in Canada is very different from the US, and there's limitations to that. You know, for example, in urology, as you know, the job market in Canada is pretty tight, whereas in the US, they're going to be looking for a huge number of urologists in the next few years. So, you know, our Canadian trainees need to have the skill set to be able to get jobs anywhere. And from a training perspective, locally, we want to also be able to attract the best trainees. So we don't want, no offense to our American colleagues here, but we don't want all of our best Canadian surgeons to be, you know, lured down to the US. We want to be able to retain them so that our patients can have access to them as well.
How many urologists a year do we train in Canada?
Probably close to about 30 chief residents a
So
year.
not a lot is what I'm saying.
Yeah.
Very good. How about in gynecologic oncology, Marcus and Joan, maybe commentary on the fellowship? You have a well-recognized fellowship and how that impacts you and indirectly how they're trained.
Yeah, I think one of the challenges is that fellows now are having to make decisions when they apply to programs that they wouldn't have had to make before. They would pick a program that they think would have a high reputation, but now they have to ask the question, is there good access to robotic surgery? Because if it does not, it will definitely limit what they will be able to do afterwards. And so we certainly pride ourselves in our fellowship program to have access to robotic surgery and laparoscopy as well, to sort of give them all the tools that they need.
Joan, do you want to add?
I just wanted to echo what Marcus just brought up, that we are in a position where we have to provide sophisticated laparoscopic training as well. But I think the days when we can choose not to offer robotic training are very numbered. They're probably gone.
And for the audience, for those of you that are not directly front line in terms of healthcare, most surgeons really start their career in their early 30s, some in their mid 30s. So you can imagine the number of years we've invested in them through mostly public funding in their education and their training. And that's a huge investment. If you want the ROI on that investment, we want those surgeons working back in Canada again and not necessarily leaving after we've, for the most part, funded a big part of their training. Any questions about education from the audience? Comments? No? So one of the things you may have seen today, and it was a common theme, was the issue of cost. I always struggle with cost studies because I feel that I can almost make any cost analysis look the way I want it to. Because I can choose what to measure, I can choose when the episode starts and when the episode closes. So if I want to do 48 hours basically open prostatectomy versus robotic prostatectomy, you're probably going to see an expensive robotic operation. If you want to look 3 months, 9 months, 12 months down the road and look at additional procedures required for strictures, et cetera, transfusions, put it all together, maybe late effects, we're seeing a higher biochemical recurrence in the randomized control trial, necessity for radiation, we can maybe spin that story and all of a sudden it's more expensive to have open surgery. So I'm going to go to Randy now. I think you've had more experience in this and you understand, I know it's mostly an American landscape, but these ideas around episodes of care, how we measure maybe, and perhaps if you can comment going forward in one of the catchphrases today of value in healthcare, and it seems to be one of the buzz terms.
Wow, they got really easy questions, and I get the hard one. So, you know, obviously the American system is different than the Canadian system, but when it comes to cost, the answer of how you measure it depends on who you're measuring it for. So who's your customer? If the customer in the U.S. is a commercial payer, then things like what we spend in the hospital doesn't matter because they typically pay us a case rate. Whatever we spend is kind of on us. It eats away at our margin. But they do care about what happens afterwards. If you're talking about a government payer similar to your system, the government also just pays us a case rate for the hospital, but they're on the line for that patient for a much longer period of time. We know based off of the value-based analytics that they've done through CMS, our government system, that at 30 days, you're typically, most of your costs are related to the acute episode itself. 60 days, you're still the majority. 90 days, you're getting to population-based health. So when we look at measuring the cost of a acute care episode, we typically in the U.S. think in 90-day episodes because anything you do from the surgery through 90 days is typically related to the surgery. Now, if in a Canadian system, you may need to think around some of the complications around side effects from procedures and what are the ongoing costs that patient may need to have beyond that. But I think the cost question is really about how do you measure the episode. For us, it's 90 days. And part of the challenge of that too means you have to start capturing costs that are outside the scope of what we have access to. And you have discrete units that have access to that cost. You have to start capturing that information in a quantifiable, objective, standardized way from all these other units and aggregating it together. It's a challenge.
Thank you. I know, Marcus, you just did some work looking at the gynecologic. Welcome, Dr. Smith.
Dr. Finale.
How are you?
I'm not here for a chat.
Urology needs
Since,
more resource.
Kevin, since you've been gone, we found $17 million in UHN's budget for robotics, so thank you.
I only came back because I heard Danny was going to donate a robot and the operating fees for a year.
We appreciate you being here. We were just... No, that's not going to do it. Marcus, you were talking about cost a bit. Anything you want to add to that or no?
Yeah, I mean, I think, as I said at the end of the presentation, I think we're going to have to find a solution to this. I mean, I think we keep kicking the can down the road, but I think reliance 100% on philanthropy to run a program like this, which is still in its infancy when we think of the future of what robotics is going to provide, and there is going to be a cost associated with that, to simply rely on philanthropy to do that, I don't think is sustainable. Partnerships with hospitals and government will be necessary with philanthropy, but obviously there are challenges with that in the budget environment that we're in. You know, I did bring up the idea of having sort of, rather than hospital-based systems, center-based systems that multiple hospitals could utilize, so you maximize the use of the tool. I guess I have a question for Randy, and you know, we often like to compare ourselves to the VA system in the US. It's about the same size, actually, as the Province of Ontario Ministry of Health. How does the system work within robotics and innovation in the VA system, and how does it get paid for? Because maybe that's analogous to our system.
I mean, the VA is a massive purchaser of robotic-assisted devices, specifically in Da Vinci, I can say. And I only know that for certain because when we negotiate on purchase prices for HCA, because we're the largest consumer, they have a deal with the government that says that nobody can be priced less than the government. So when we negotiate for robots, we're negotiating for the government too. So I know how many robots they buy too every year. It's a huge investment. And they've done it initially, obviously, with urology where it started, but it's broadened now to include gynecology and general surgery. It's advanced along with the technologies, and they've continued to invest in that. It may be a little bit different. I mean, there are dollars that are set aside for that system itself. We're treating folks who have given themselves and oftentimes their health and their loved ones' lives to the country. So there's a little bit less desire to kind of pull back in terms of funding in that sense. But no, our government has invested massively in robotics in the VA system, and it's paid for through the typical VA funds. And they're similar to Canada. They're on the hook for the cost of care for that patient for as long as that patient lives. And if things were creating an insurmountable or untenable amount of cost, they would get cut off.
Oh, very good point. In terms of philanthropy, the UHN now, we're probably well over $15 million that we've raised towards robotics and used already. Is that, Marcus, is that number sound about right since 2008?
Yeah, I think when you factor all the costs, because it's really been a complete envelope of funding, it's a sort of a separate element within the hospital system. So yes, I think that's probably accurate.
I wanted to ask Dr. Hanna a couple questions. Maybe one, if you could describe the system in MAC and the evolution of philanthropy, and if there's any blended models on the horizon. And second, thoracic surgeons also like to fire a lot of staplers and use other things that are not necessarily philanthropically funded, and maybe make a comment about other technologies.
Yeah, so we learned robotic thoracic surgery at UHN, and we exported the model of the operating room there. In terms of funding, the major donor who gave us our first large donation and second large donation had a stringent criterion that we had to adhere to, which is produce research and make it self-sustainable. And these two go hand in hand. If we were going to convince the government or our patients even, or our physicians that robotic surgery was worthwhile, we had to show the data. So we created a robotic research institute under the umbrella of the Boris Family Center that did prostate research, kidney research, and thoracic research. We did retrospective trials, prospective trials, etc. So with the production of the research came grant money, and grant money allows you to enroll patients on research budgets. So part of the disposable is being paid off by the foundation, mostly, but a lot of it is covered by research budgets if the patient's on trial. In thoracic surgery, 90% of patients undergoing robotic surgery are on trial. And so this whole building the research program allowed to gather attention and funding, but it is mostly philanthropy. The other thing that happened was that at our last meetings with the foundation, the donors that started the program said, okay, now we've gotten you started, now you're on your own. So we have to figure out how to continue to raise funding, continue to do research, and the hospital, after this 10-year endeavor of us being fully committed to the project and doing research and enrolling patients and raising money, decided that they would contribute as well. So it's a blended model of 3 different sources of funding. I personally think eventually the government will have to pay for it, because this is, in thoracic surgery, this is where we're going. Lung cancers are going to get smaller and smaller, and patients are going to get more and more informed. Patients are not going to want a massive thoracotomy and a massive lobectomy for a 9mm tumor. And eventually, when the numbers and the data and the patient voice is on your side, eventually great things will happen. So I'm confident.
Kevin, do you want to comment?
Oh, I'll just add, having been there and here now, I guess the other piece is just a word of caution around philanthropy. Those philanthropists, very generous philanthropic family, did get to a point of irritation where they said, well, when we started all this, it was a let's prove it works, we've done that, and they will fund it. And I think when I was making the transition, there was that frustration of the philanthropist who said, look, we know it works, there's evidence it works, it's been introduced elsewhere. If they're not going to fund it, we're not going to continue to fund this forever. We're here to inspire innovation and bring new technologies to the environment, to the academic environment. But when it becomes the standard of practice as a philanthropist, we're going to step back. So if others are thinking about philanthropy in this model, very important to help philanthropists know what the trajectory is, because they do eventually get quite frustrated in saying, but we want you to now fund what is clinical care.
Sometimes it's difficult to conduct that research if it's already standard of care everywhere else.
Absolutely.
So, for example, to try to reproduce a robotic partial nephrectomy trial, I don't think there's a single journal that will accept the publication that we respect in urology. I think thoracics, maybe you were ahead of the curve here in terms of the ability to get grant funding, and that's kudos to you.
We're a bit fortunate because thoracic surgery is very new to robotics, whereas urology and gynecology, you guys have been there decades now. And so the questions that we have to answer are very different than the questions that you have to answer, and so we've learned from your trajectory.
Tony, could I just
Joan,
say,
please.
The other thing I'd like to add, that there are a lot of doctors in this room, and I guess we're not very well known for our financial acumen, but for the business people in the room, how many of you would make a multi-million-dollar investment and let it sit idle half the time? And I think that's another very important part. I'm very proud of what we've done at Trillium Health Partners, but one thing that we're becoming acutely aware of is that our investment is not being managed to the best of its capacity because we just can't fund it. So there's that other side of the argument too. If we can do good things for people, but we can't fund it, and we're wasting some of that investment. It's a problem.
Absolutely. I have a couple more questions, but any questions or comments from the floor? Anyone? Marcus, it's not your space, but how does the Alberta HTA use the same data and fund robotic prostatectomy, and our elite HQO looks at the data and feels that perhaps it's not sufficient?
Yeah, and in fact, I touched base with my Alberta colleagues just the other night just to confirm, and they did confirm that these are cases which are completely covered. They are covered.
Should we separate with them? We can join, right?
And we don't even have the excuse anymore to say, well, they're swimming in oil because the price isn't what it used to be. So, I think, as you very well know, with any data, with any paper, it depends a little bit on how you interpret it, and it can be interpreted in different ways. I think the Ontario interpretation was a very stringent interpretation. And I think the Alberta interpretation of the data was one acknowledging the limitations of the data that's there and not discounting all the other positive elements that exist. So, I think that's what it is. I think most people would feel that the Ontario interpretation that would say that for removal of a prostate in 2020 in Ontario, it should be done through an open procedure rather than a minimally invasive one is challenging ultimately. I think
Kevin?
Yeah, I don't think any agency would say open, and I think we have to be very careful even when we quote data to funders. So talking about open to robotic is, in my opinion, not going to win the day. It really needs to be laparoscopic to robotic, both in terms of cost structure and in terms of current practice. But I think the other thing is we have to be a bit careful what we wish for. Those of us who deal with government frequently, if they were to say tomorrow, great, we're going to cover it, but we're not going to increase your transfer payment. We're now asking you to cover robotic surgery. And if there's no ophthalmologist, I suspect, in the room, but those of us who can remember foldable lenses when they came into the marketplace, some ophthalmologists were saying, well, if you want a foldable lens, it's an upgraded cost. It's not medically necessary. We all know that term. So you can charge for it, until a patient said, I'm going to complain about that. And it caused some media frenzy. And the next day the ministry said, you're going to cover that now. They didn't give hospitals any extra money. So, surgical programs who are potentially embracing this, if the ministry says tomorrow, okay, we're going to cover it, it'll probably be within the envelope of funding we have already. So it will be back to, what do you want to not do in order to do this? And many of it, we've all faced that in Ontario hospitals for many, many, many years. I still think that would be a better outcome than not allowing it, but it is not when they approve it, new funds will flow, has not been the history of this model in most funding regimes, and that regardless of political party.
But when you can only do a certain volume, there's an ethical side to this. And not to put one specific surgeon on the spot, how do you decide who's going to get the robot and who's going to get the open operation in your practice? Marcus?
At UHN in our program, we took a strategy that I always say in some ways was the appropriate strategy, but in other ways we have probably let ourselves down. What we tried to do right from the beginning, and this was even under Joan's leadership, to be as judicious as possible, because these were philanthropic funds, to only do those cases that we felt were the absolute most challenging. And so to try to maximize, if anything, the return on that payment. Of course, what that does over the years, it makes it difficult to really push a program forward if all you're ever going to be doing is the very challenging cases from an educational perspective for trainees, just in terms of building the program. I often will say that, my counterpart, Dr. Gottlieb in Montreal, really went all in on robot and said, look, if we're going to try to improve this, I have to be given the full access. And so, I don't have an answer to your question in terms of how do you choose one person over another, but I think if the resources are limited, you are somewhat forced to kind of where that maximum benefit lies.
Another area that, you know, I don't think we talk much about is wear and tear on the surgeon. And I don't know if Randy, maybe if you have, I know there's definitely some literature in the United States about ergonomics, and Kevin mentioned it should be laparoscopy versus robotic, and I think I'm one of the few who did hundreds of laparoscopic prostatectomies, to be exact, about 350 before I switched over to robotic. So I clearly remember the days of what I did and what I do. My days are better now.
Yeah, no, it's about the same for me. I mean, I did about 350 or so lap before I transitioned over to robotics. Probably similar to you, I could only do 2 lap in a day. I was just too flippin' tired after 2 of them. I mean, it's just hard standing over the patient, leaned over, looking at the camera, angled over doing that. It's really physically wearing. Whereas for robotically, we were doing 4 a day, and comfortably, finishing up, 4 o'clock or so. Mentally fatigued as you would be after a long day, but not physically fatigued. The ergonomics it's interesting. My daughter and I love to watch hockey. I grew up in Buffalo, New York, and it's close enough to Canada that we are the largest consumer of Labatt Blue per capita in the world. And we enjoyed growing up, watching the Sabres. And you watch hockey, of all sports, they swap out people more rapidly than any other sport that I've seen. I mean, they're getting fresh legs on that ice all the time, because as an athlete who's functioning at peak performance, you get tired and you can't perform as well when you're tired. I can't imagine the same isn't true for surgeons. I mean, our ability to function properly, to do delicate, precise work, and to think effectively, making hundreds of decisions per second, it's wearing, and I there's no quantification of it, but I have to believe that when you can eliminate physical fatigue from a surgeon, it allows them to function mentally and from a quantitative point of view more effectively for a longer period of time. I really believed that while I was operating robotically, I could give my last patient as good an operation as my first patient. I was not tired.
That's a very good point. I mean, there's data out there on surgeons' longevity with back injuries, C-spine injuries, shoulder girdle injuries. Zane, please.
Tony, I would like to ask you a question, and that is, in Ontario, I'm not a urologist, as you know, I believe what you say, that it's the standard of practice to do prostatectomies, MIS. What is the percentage of prostatectomies in the province that are done with an MIS technique, whether it's laparoscopically or...
So if I'm not mistaken, I think there aren't any laparoscopic prostatectomies currently. I feel there was a handful of surgeons who abandoned, some of which went to open and some went to robot. I could be mistaken. There was a few in the community as well who were doing laparoscopic prostates, and maybe I stand corrected. I think we do about 2,700 prostatectomies a year in the province, and my guess is we're probably hitting about 800, 900 robotically. Someone from Minogue might be able to correct me, but I think we're about 900 roboprostates a year, 1,000. Does anyone have the data? No?
There's another advantage. I mean, obviously
Does anyone have the number or no? 2,500. Total? Or not robotic?
Not per year.
It's not. It's okay, Al.
We don't
It's
have
fine.
the data.
I know. It's 3,000 radical prostatectomies a year.
Canada.
No, not Canada, because then you got Alberta. So go ahead, Zane.
there's another potential advantage, because in the colon field,
Right.
it's been very slow to bring colon surgery to the MIS field, and now if it progresses, obviously, you can do it with single port. You can do it with a tiny little incision. You don't need 6 incisions. So, I don't think we should be arguing about the incisions. Whether you
No.
have 2 incisions, no, I don't.
I agree.
Whether you have 2 incisions or whether you have 6 incisions, you're still getting the patient out of the hospital very early. So the question is not the question, I'll ask the question in a minute. But I think, and I'm not sure, I'm not a robotic surgeon either, but I do believe that it's easier to take an open surgeon to robotics than it is to laparoscopy.
100%.
And that, I think, is a tremendous advantage when you're thinking about minimally invasive surgery and converting open surgeons to a minimally invasive technique.
So
I think
we've seen that in
is-
prostatectomy too,
I
absolutely.
think that's really a very important consideration.
And I'm sure Marcus and Joan can comment on the gynecology space as well in terms of that.
Yeah, I mean, I think the first laparoscopic hysterectomy was 1987. We have data from 2005 that only 25% of hysterectomies were done in a laparoscopic fashion, and that's sort of pushing the envelope with laparoscopy. And so, you know, I think there is a reason that laparoscopy can take you so far to what was sort of said earlier. There are, obviously, it's a very good technique, and there are improvements. There are even sort of robotic improvements within laparoscopy, if you will. But there's no question, as a platform, the robotic platform allows you to do more. That's sort of the key.
And I think there's some very nice curves that'll show uptake of MIS between laparoscopy and robotics in Canada and other parts of North America. And it's very clear the robotic uptake, the curve is much more rapid than laparoscopy ever was, or ever will be.
So Kevin and I were just having a little conversation here, and I'm going to put Kevin on the spot. He's going to ask a question and stimulate some discussion. You want to go ahead?
So, you know, at the end of the day, Zane, you and I have had this discussion. We've all, Jay, you're doing this every year. Every year we're looking for 1 or 2 or 3% savings because the cost of hospitals basically goes up by that amount. The majority of our costs are fixed around labor. It's 70%, 30% are variable, but they're in things that we don't have a lot of control over. Foreign exchange, buying drugs, buying implantables, all of which are from outside the country. So when you look at this one, I think the anxiety about any new technology that's predicated on it's better, safer, cheaper, faster, is are there actually savings? And Danny and the Minogue folks may want to comment on this, but I think the more we can move towards a model that says we could actually save enough activity through this model that we could reduce the number of inpatient beds required, convert that savings into a cost per case that doesn't exceed what we're doing today, and if we don't, share some risk with the vendor and or the surgeons, then you've got a much more palatable approach than, gee, I'd like to figure out how to do this in a fixed cost, increasingly declining pie that every year gets 3% smaller. Danny, are there any examples of risk sharing, and are there opportunities to see that if surgeons and hospitals follow the appropriate parameters and they don't realize the savings, is industry interested in risk sharing?
Well, there's 2 things. One is that, and it's been mentioned here today a few times, the episode of care. And we've gone to a number of hospitals and said, you know, if you look at the total cost of a patient going through versus open or even lap, it's going to cost you less to the system robotically. However, if you can put 60, 80 more patients through because of you know, length of stay, savings, etc., you're going to be able to have all these patients theoretically go through and reduce the waiting list. So, but who's going to pay for that? Your existing budget, is the government going to give you extra funds? Sadly, the answer is no. So what can we do as a vendor? Unfortunately, there's only so much we can do, but something that we've... Hey?
You can always do more.
It's funny, are you and Kevin on the same team?
I rarely disagree with Zane.
Yeah, I can see that. So what we've done more recently, and in conversation with our manufacturer, is a decision has been made to reduce our costs that we charge the hospitals across Canada, so that we're able to get even closer. Even though there are cost analysis that YL came out with that Walter Gottlieb has spoken about, and it's all there, it's all very nice, but when you go to the government ministry and say, well, look, we can save all this money, they're going to come back and say, well, we're not going to give you extra money. Just so, and like Kevin says, you've got to use your budget to fund robotics. Yeah. So the best that I can offer right today is that we are reducing our costs. We have reduced, as of October 1st, by around 20% And if your hospital is doing $500,000, $1 million a year, that's not insignificant. So that's
There is one vendor risk-sharing model in the U.S. that I believe that is actually a true risk-sharing model, not some BS marketing scheme. It's Medacta, and they make hip and knee replacements. They do it for their knees. And Medacta actually goes at risk over a 2-year period of time following the implant of any one of their knees. And the way that they've done this, it's interesting. They think about it as longitudinal risk, where there's different risk that they take at different episodes in time. So in the first 90 days or the first 30 days, there's a certain risk that they'll take. In the next 90 days, there's a certain risk they'll take. When you go beyond 90 days, they'll take another series of risks. And the reason they're comfortable for taking risks in spaces where they have no control is because they've taken an exceptional amount of control over the surgeons that they allow to use their product, the techniques those surgeons uses, and the mechanism by which they make care pathway decisions. So I think if we're going to ask vendors to take risk in a space, we're going to have to place some control over some aspects of care across the continuum.
Yes.
And that means that we're going to have to look beyond everybody can use it however they want, whenever they want, and this person's going to have to take risk. You have to create some controls. And the Medacta example is actually a very interesting one that we're looking at, thinking how can we replicate that concept of longitudinal risk with controlling subsegments and allowing each kind of group of folks to take control of those different steps.
Can I add one more thing, Tony?
Oh, go ahead, Kevin.
I think I wasn't here. I apologize to CYL's, which I'm sure was excellent presentation, but big difference between cost avoidance and cost savings, which is usually confounded and confused in healthcare. And there's a very simple question. It's not a pleasant, attractive, or even very nice question to ask. But tell me out of this intervention how many worked hours I will be able to reduce. Those are cost savings. Tell me how many more people I can treat. Those are efficiencies. And I think the more we can get to a model that says, look, we can actually close inpatient beds because of this conversion, or we can close outpatient clinics. There are true resources to redirect. And Danny, I know you know this already, but we don't get to theoretically balance the budget. We actually have to balance it in legislation. So I think, I don't know, and I appreciate you're the meat in the sandwich, but if Da Vinci and others are, when we get to a certain volume, interested in a better risk-sharing plan where there is actually some reward for that risk, I think that's an attractive environment for funders as well as for hospitals. And I agree, don't do it alone. So just recently, Mount Sinai and UHN and others, you're right, we're leaving these very expensive pieces of capital equipment too often in a dark room with no light or no surgeon or surgical nurses. We don't need to buy this separately.
It's a great point. And one thing that we didn't talk much about, at least for the section that I was here on, is the cost avoidance piece. You know, when we do cost modeling as a hospital system, we think about our actual costs. When the government looks at cost models, when we had our bundles in the United States, we get a lump sum of dollars, and those lump sum of dollars are for the episode. That includes complications, readmissions, reoperation, medications. So when we think about the cost of an episode, we can't look at the cost of a patient who has an operation one way versus another and goes on for this period of time. We have to look at the percent of patients who are readmitted, who have complications, who have a reoperation, who utilize opioids, who go on to have other complications as a result. Those are real costs to the system. And as we think about episode-based cost management, I think you're exactly right. The cost avoidance piece is a real cost that needs to be included, especially when we're talking about different modalities of treatment.
So we've had that natural experiment at our hospital, and Marcus and I went through the exercise that if we stopped doing robotic surgery, I can tell you right now, we wouldn't be able to do what we do. And prostate's not the greatest example because the length of stay difference is a day at most. But the efficiency with which we run and get our next cases in the next day, because I know today's are going home tomorrow. Right. With the tight beds that we run, we wouldn't, if we stopped and went back to open, we would have a bed crisis, at least on the urology gynecology floor, almost certainly. So it's already taken place, the natural experiment. It's almost, now what do we do? Because if we go back, we're not even going to get to do what we were doing. Marcus, you're going to say something?
Yeah, no, I was going to ask a question for Kevin that it's not an easy question, but you have a big job, and so you get the tough questions. You know, I think as you talked a little bit about some of the efficiencies that can be obtained, and unfortunately, sometimes we see the negative effects of that. So we've seen that firsthand in gynecologic oncology. We've done a very good job, and we've been sort of at the forefront of trying to have people go home the same day and having same-day surgery. And so what that's done is it's created a case mix index that has been lowered because it's, oh, you're doing a great job. We're not going to pay you. You just saved a lot of money by doing this great thing, but now we're not going to pay you for it. And I just keep circling back to what you were saying is that you're going to have to make choices, and ultimately these are choices that you're at some level going to have to make. Do you envision at some point a model that is just not going to function that way anymore, because those decisions will start to get tougher and tougher as you get more and more technology?
I think you're right. It is happening, and it will happen. And to your earlier discussion around the ethics piece, I think we often forget we actually have very highly skilled clinical ethicists in our institutions. I don't know if we've ever actually asked them to look at robotics or not. If we haven't, we should. But they actually have a framework for looking at let's call it what it is, rationing, number one. Number two, I think we constantly try to make inroads, and our foundations make all the difference on this, that innovation isn't free, right? You can't be innovative and maximally efficient in one step. If we're really an academic enterprise, we'd use the academic literature on innovation. And it's clear you need to make an investment, let that innovation take hold, demonstrate its effectiveness, and then introduce efficiencies, which will drive down the cost. We are, I think, getting more receptivity with government around the innovation cycle, but I'd still say we're back at in a system that now spends 44 cents of every tax dollar in Ontario, at a point where we know our healthcare system, the delivery side of illness care, is about 25% of health, spending 44 cents on every dollar. It is getting very much at the margin. And the last discussion is what pieces of these would one adjust cash flow on. And I'll mention a very dirty word in an audience like this, but it comes down to, I think, a difficult discussion around relativity. How much is each procedure worth, and a schedule of fees, and skill mix. Do you need to have, does everyone in the room need to be a nurse or a nurse practitioner or the most expensive people, or can we increasingly with technologies look at fewer expensive people over a larger number of operating rooms or a larger number of units of care produced? And I think it'll be those kinds of efficiency discussions. Our American colleagues are pushing this envelope because of the nature of 5,000 billers. We have the challenge of one biller and a minister who gets held accountable for every bad outcome or every decision that's made. And I'm very sympathetic to any minister that a question gets asked in the House about how an individual patient was managed. The minister's very far from that, but unfortunately held to account on that. So I think we're going to have the discussion, but I think it's going to come back again to, with our foundations, can we make that innovation investment? And then with the private sector, can we find some models that would actually look at this around scalability? And last point is, one comes to a point where we'll have to actually say, and I don't think, Tony, we've done this well, we may have to actually say to the funder, we are going to have to stop the service, right? And I know for UHN, I've been up the road enough times looking for money. Every time we say, oh, it's a crisis and we're going to have to stop the service, and we don't, the perception is, well, they figure it out every year. Why would we give them any more money? Right? So I think you can't cry wolf on this one. If you're actually out of money, you need to actually start declining clinical volumes. And I hate the thought of putting the patient in the middle of that. What's even more unfair is to ask the frontline practitioner to practice health economics. I think that's where the management team and the board have to go back to the funder and say, we're capped in volumes. And so we're going to have to turn away people who are non-emergent. Very unpleasant, but I don't see a different way for the funder to make a decision about investment.
A very good discussion. I've often wondered, changing gears a bit, we go to HQO per procedure, and really what we're talking about is a platform. I mean, the OR of the future, and really bringing technology to the OR, maybe turning a robot into an iPhone that goes much further than articulating instruments with depth perception, but it's something that for QI, for education, for safety, like the black box, like all of that bundled in one. And it's almost to me analogous to when a hospital is going to drop $100 million on an EMR. Are you really looking at a culture change and revolutionizing your operating rooms, or are we going to continue to go at this one piece at a time? Everybody plays on the robot. Everybody sees if their procedure is cost effective. And I don't know, Randy, if you've ever thought about this or not. I don't want to scare the payers, but in my mind, this is a platform change. If we're ever going to move surgery forward, it's the stuff you showed, the stuff the other speakers showed, that it's going to only be harnessed through technology in the operating room, not through an incision wearing loops. That's the way I feel about it. And I just don't know when we'll ever get there.
I mean, for us, you know, the payers have always, our commercial payers have always put the onus on us to kind of figure it out on the cost side. But I will tell you that, you know, our government's foray into value-based care and bundled payments is actually allowing us the opportunity to have conversations with payers around how do we change the risk paradigm? How do we think about a different transactional model between surgeon, patient, hospital, and payer? What does that look like? How do we move from participants with similar goals around parallel tracks to folks where everybody's in the pool, and we all bear some responsibility inside of that? So there's, I mean, I think the system has to change because we can't afford to keep on just. It's the Margaret Thatcher quote. You know, the problem with socialism is eventually run out of other people's money. You know, we are running out of other people's money, and that means that we have to change the conversation and change the relationship between our hospitals, our payers, our surgeons, and our patients. And that's something that I probably spend 80% of my time with our payers trying to figure out.
Perfect. I want to just give one last chance to the audience, and I'm gonna wrap up. Any comments? Any questions? Jack Barkin, and in the front here as well.
Yeah, so listen, thank you. A couple of minor things. So first of all, Humber River was actually the first community hospital that had a surgical robot. My colleagues are here as well. So we started that back in 2012 by a private funder, a donor, and it was a tough battle, as Danny will recall. But the key is in each hospital, if you're going to do this, you need a real champion. To really push it forward, to convince the board, convince the funder, and the support for this thing. Second thing, your comment, Jason, about private hospital care or private care. We have a very select company. It's Canada, Cuba, and North Korea. You forgot North Korea as the only 3 countries in the world that do not have any private health care at this point in time. But going back to what we said, and with respect to Kevin's consideration, patient care from our government standpoint is truly a euphemism. They don't really care about the patients, they care about the economics of the whole situation. Part of what we talked about is episodic analysis, is if you put all the silos together, there's no doubt that minimally invasive surgery, whether it be done robotically, laparoscopically, or whatever, gets the patient back to work faster. Their quality of life and improvement is quicker. They're paying their taxes sooner, and they're not living off of their disability insurance for as long as if they had open surgery. With respect to the consideration of saving hospital beds, I think we've kind of reached the margin. There's not that many more surgeries. 30-odd years ago, I brought laser prostatectomy to our hospital, the old Northwestern General, with the intent of saving hospital beds. In those days, you could do that. Today, we can't. Over 80% of surgery is being done as outpatient surgery already. We're really shrinking that envelope to tremendously. So that argument is no longer valid, unfortunately, although it seems to be a great thing. So your concept of mixing availability of the higher priced support staff and or physicians, or trying to decrease our cost of particular procedures that it can keep up with the technology, is the only way it's really going to work. Or if you can convince the government that this is a partnership, because it's only one government that's paying for our health care, so if they get their taxes sooner from the revenue from the patient going back to work, you shouldn't exclude that from the consideration of the value of doing minimally invasive surgery. I think that's what we've got to play today.
Thanks. Last comment, question, please.
Deborah Robertson. I'm a general gynecologist who does minimally invasive gynae surgery at St. Mike's, including robotic surgery. And I think, first of all, I want to thank everyone. I think this was a really good afternoon and a great conversation to bring us all together to advocate further. I think when I think about how we've kind of advocated for this, I think we're never going to be like the US. We really are, and I think in a good way. What I heard from the different speakers and the different specialties is we all really know which one or two surgeries within our specialty can benefit from this. And I think that where we might have made a mistake at going to the government is saying we should, allow for robotics and looking at a cost from a global stance. But we're not like the Americans where we want to offer robotic surgery across the board. So I think we need to be more specific in our asks. I know that for myself, as a gynecologist, really for the patients with the high BMI, as we heard from Dr. Jantz, that was really a compelling argument that we really have to advocate for these patients, because I actually worry about losing funding for the robot because I just won't be able to offer surgery to these patients at all. And this is it almost becomes a discrimination argument. So there's always a cost argument in going to the government, but I think advocating for this underserved population that across the province is just not getting access to the surgery that they need. And it's probably, with the research that we're looking at, is that they're probably not getting surgery at all. I think at one point we'll have to lead our argument as well. Sometimes it's more than just the cost, as we heard from the patients today. I think that we'll have to look at advocating for these patients too.
Thank you. I think on that note, I want to thank all of our speakers. Thank you again for attending today, our organizers, and have a great evening. There's some refreshments at the back.
Yeah, you know,